So I did add some stuff to Brightspace this morning. Please do not panic. It is not like 8 chapters of new stuff. Please, I can't handle any panic this morning. It is only for me to make sure that I am covering my bases. I am using new like lecture material that is different from the last time I taught this course, because I feel like previously it was just kind of like, I don't know, I just didn't like the design of it that was provided by the book. So I wanted to kind of do my own thing with the same information. So again, please do not panic. Yes, there is new stuff. They are short, and whatever stuff that we've already covered, we're just going to have like a very, very quick, like we talked about this. I did post the previous video to YouTube. It is still processing. So by the time class is over, it will definitely be available to be like watched and everything. So please don't make me ask you to turn your cameras on all day, because I won't do it. And yeah, let's do this. I'm gonna go see if my thing is done copying. I'll be right back. Just 3 more packets. Okay, so did everybody see my email about the math?
Yes.
Okay.
Yes.
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 There was, I literally found out that my mother was a hoarder yesterday. not like hoarding, like buried alive, but like hoarding nonetheless. And I spent like 3 hours at the funeral home making arrangements. And then, I spent like 8 hours cleaning her house. Like, and they smoke so they smoke so much in the house. Like everything was sticky, everything was yellow, everything was smelly. And my hands are so dry. Now it did get rid of the orange. So, you know, there's a silver lining. But my hands are so dry. I'm not kidding. I probably changed the water like 50 times within that 8 hours. Like it was so gross. So gross. If you smoke in your house, please stop. So bad. So yes, the math. There was a lot of confusion. We do not have an ATI module in this class. Okay. The only requirement for your math test today is that you did the math worksheet on the first week in Brightspace. I don't know what to say to that.
I'm sorry. Can you? So I did the little quiz that you had on there under Math 1 Week 1, but you also want us to do the worksheet and turn that in before today?
There is no worksheet.
Okay, I don't know why I thought I just heard worksheet.
There, yeah, I mean it's named worksheet, but there is no worksheet. It's a quiz.
Okay, so that quiz I took is all I needed to do.
Yes.
Okay, perfect. Sorry, just confirming.
I don't know what to say. This is our first time doing this with the math this way.
And it also said to print it out and bring it. Bring it? I don't have a printer.
No, guys, you're not listening to me. There is no math module. If there's no math module, there's nothing to print. Right?
Right, that's what I was thinking, but I didn't know if they wanted us to print out the screenshots we took to upload it or what the heck.
You don't even need to upload anything. The quiz you took is on Brightspace. If you took it, I saw that you took it. You know what I mean? So like currently, as of right this very second, very second, I can tell you that 48 out of 52 people have taken their math worksheet. That's a wonderful number. I love that number. That's a great number. So that means one. I'm pretty sure I'm counted in that overall number. And I don't need to take it. So if you have not taken that math worksheet, you will not be able to take your math exam today. Do you know where the printer, where our like faculty, not this way, the one where the microwave? Yes. Yeah. They're done printing by now. I'm gonna have to ask Terry, what time are you leaving? Okay, do you have like an appointment? Because this was on our schedule. Oh, I emailed you back this morning that it would be fine for him to be here. Isn't that what you said? Something about him sitting in the hallway with his headphone? No? Okay, somebody else said that to me. Literally, like, same situation. Was like, I have to go get my son. Can he sit in the hallway? What? The door's closed. I was just open. I wonder if we have a lunch range. People explain it as we're being. I forget what to do. So, no, like 11:30 to 12 or 12 minutes that we went. Yeah. Yeah. Like 12-ish. It was like way before it got done for the baby. Oh, so feel like saying. Yeah, like I would go right to like talk to Terry, she's in her office, just explain what's going on and say, I'm willing to do it during my lunch break tonight for that today. So it's early. So her role is actively not. I tend to know she passed, but Tuesday she so she to be honest, not making any excuse, but Saturday, I was just a little on there for. Like this time obviously isn't ideal, but I'm willing to do it because it's not like, oh, it has to be after we investigated. It's kind of. The only thing with that, I would say,
Wait, so literally, you would technically need you an advanced or disadvantage? It wouldn't be right now, but they.
You know what I'm saying? Like, just thinking that they're doing a week one, which is different. Have it 3 times, like this week, have 4 times. You get what I'm saying?
No, this would be for week one, like if she's looking at lunch. Then. If she failed that lunch, then she could take next. But they.
That's what you were saying.
Yeah, I see.
For no, this ain't one of the. I know, I thought it started thinking.
You thought,
Yeah, no, but no, that's what I'm saying, but now it's like, they get as fun to do this week. Because
because we won't have one. We have it.
So it's still
after,
serving.
yeah, we have it 8 steps after the first stage class, and then we're fine. It's 2 months, essentially. It's your feel last week, yeah. Because they got like after, which is like
Yeah.
the comprehensive. It's the same setup, but it's
Okay, so these are already in order of the chapter,
awesome sauce.
and there's 8 copies, so just take one off the top and pass it.
I got it.
Sure?
Yep. I got it. She's like, don't drop them. Oh wait, come on, they're just like that top one. That's like oh goodness. Yeah. And I was gonna say, the only thing they might say is they don't mix it at lunch, she gets other things. You know what I mean? Like, say next week or next week.
Well, she
Oh, she didn't say that.
She said she.
Oh, I got it.
Yeah.
Gotcha. I thought she just meant.
She said.
She must have referred that.
Yeah, she gave that to me anyway, so.
That's like, well, if that's the case, then you know that
Which
which
she can say something.
You don't got your doctor's in medicine in it.
Something got staplers? Yeah.
It's
no, it's not. See, I'll start here. It's this after. Neither front and back.
Um,
I did. They hopefully like,
a lot of shit.
Do we have the papers?
yes.
Okay, alright, let's get started. Cause it's been a whole 24 minutes and we have not started yet, so. There they go.
You might want to.
Oh. And they're in order, the way that I printed them. So,
I'm just trying to figure out where to staple at, that's all.
oh, you might not be able to. Okay, so we're literally just going to do a quick overview. Because this is chapter 42, right, from the beginning. So I just want to make sure that that I didn't miss anything. I want to make sure I'm covering my bases, because obviously my head is like half in the game. But I also don't want other people lecturing for me because I know what's on my exam and I know what I want you to know. And I don't think it's fair to put that on. Now, if my mother died today, that would be a different story. But that is not the case, and that is why I am here. So, am I recording? Yes. Okay. So, if you haven't seen yet, there are obviously more PowerPoints on Brightspace in week 1. It is not new material, it's just material that I want to make sure I cover. So anyway, we talked about the blood flow through the heart. We talked about that on Tuesday. We talked about the arrows. We talked about the oxygenation in the lungs. And we talked about how When we go from the right ventricle, we go through the pulmonary artery because it's opposite in the heart and lungs. Usually arteries carry oxygenated blood, but in the heart to the lungs and the lungs to the heart, it's backwards. So the right atrium goes into the pulmonary artery and then into the left side of the heart, right? So this is just a little overview of that first chapter, just to make sure I didn't miss anything. We went over this. This is definitely a nicer picture, I feel like, than the previous. So we have our superior and inferior vena cava goes into our right atrium through our tricuspid valve into the right ventricle, which then goes out through the pulmonary artery, okay? Through the pulmonary artery into the lungs to be oxygenated, okay? When it comes back from the lungs, it goes in through the pulmonary vein, into the left atrium, through the mitral valve, into the left ventricle, and then boop, to the body, okay? So we know we have a pulmonary circulation of where our blood gets oxygenated. We also have our systemic circulation, which is the circulation throughout the entire body, right? We talked about the cardiac conduction system. We did not talk about the difference between systolic and diastolic pressure and what that means, okay? So diastole is when our chambers are relaxed. It's relaxation, okay? Systole is contraction. So diastole, it is when blood returns to the heart. Systolic is when blood is ejected from the heart, okay? This is just like a good to know, right? Because remember, we need to know how the body works in the first place before we figure out how to fix it when things go wrong, okay? The only thing we didn't really talk about was this atrial kick, the final squeeze to fill the ventricle. It's just your atrium filling the ventricles. So fueling the engine, we talked about that our heart has its own coronary arteries, right? It has its own blood supply. We talked about that on Tuesday. It's the only muscle in our bodies that has literally its own oxygen and blood supply that wraps around the heart muscle, okay? See these red vessels here that wrap around the heart? Those are your coronary arteries, okay? So, coronary arteries feed specific regions of the cardiac fibers, and then blockage also, obviously, if we're talking about an MI, a blockage is what leads to ischemia in that muscle. So ischemia meaning death of those tissues, right? From lack of oxygen, okay? Timing is key. Unlike the rest of the body, the heart receives its blood flow primarily during diastole. So think about this. When we talked about the contraction and dilation, we talked about the conduction system. Remember, we talked about the SA node fires, but the AV node says, okay, take a second, because we can't all contract at the same time. We have to have some relaxation between those chambers. So if we didn't have diastole, if we didn't have the relaxation, our heart muscle would never receive oxygen. So if you think about it in terms of arrhythmias, dysrhythmias, if our heart is going crazy with this crazy rate, you're in SVT with a rate between 151 and 200, when is your heart relaxing enough to get blood flow? which is why when we have these life-threatening arrhythmias, that's why. Because we can't sustain these things because we're not getting oxygen to that muscle, okay? Pulse pressure indicates the filling pressure of these vital arteries. This is just part of the equation of blood pressure, okay? It's more of a good to know. We talked about the conduction system, okay? We talked about the SA node is a pacemaker of the heart, right? It is what sets our rate, our 60 to 100, boom, 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 right? Then we get to our AV node. This is the brake. This is the delay. This is the, hey, wait a second. We need to chill for a second because our atria just contracted and we need to fill the ventricles, okay? We go into the bundle of His, which is right at the top of where our where the septum is, the middle of the two sides. And then it goes into our Purkinje fibers, which wrap around our ventricles to cause ventricular contraction. Okay. We talked about automaticity. Automaticity, the unique ability for cardiac cells to spontaneously generate. So this is our self-driving mechanism. We don't have to tell our heart to beat. This is our body beating on its own, or our heart beating on its own, okay? Conductivity is the ability to transmit those electrical impulses. And then down here, the autonomic control. So the sympathetic nervous system increases your rate and force. This is your fight or flight, right? When you get anxious, when you got to run from the bear, this is when our heart's racing, okay? And then our parasympathetic, this is when we decrease the rate. This is our relax, okay? Our rest and digest. I'm going through this quickly because we already talked about all of this, okay? So I really want it to be more of a refresher. So if you need me to stop at any point, you have to tell me because I really wanted this to be a just a quick overview, okay? We didn't really talk about the action potential cycle. This is important because we talked about calcium channel blockers, right? We talked about sodium channel blockers when we were talking about antihypertensives and antiarrhythmics, okay? This explains why, okay? So if you see over here with our phase 0 with depolarization, it says there's a sodium influx, okay? And if you see up here in phase 2, the plateau, where contraction occurs, there's a calcium influx, okay? So the thought process, the mechanism of action, if we're blocking sodium from influxing, right, in depolarization, which is relaxation, this is a way for sodium channel blockers work mostly with arrhythmias. But remember, I told you they're not common. Sodium channel blockers are not common because sodium is a finicky thing. You don't want to mess with sodium very much, right? But this kind of explains why that mechanism of action works because you need an influx of sodium during that depolarization. That's what's happening normal during your cardiac cycle. Okay, so then when your ventricles contract and you have calcium influx, if we have a person that has an arrhythmia and we have 2 calcium channel blockers that we talked about on Tuesday, that is specifically for arrhythmias. Do you remember what they were? I mean, they're basically my favorite drugs. My drugs of choice. No, close. It is a D.
Diltiazem.
Diltiazem. You're so close.
Oh, but
Hey, you were close. I think if it was on a test, you would have recognized that that was it, right? So diltiazem, and what's the other one? Verapamil. Okay, those are our special calcium channel blockers that work on arrhythmias. The other ones that end in dipine, like amlodipine, those are our other calcium channel blockers that are antihypertensives, right? But this kind of helps us think about if it's helping or blocking sodium, calcium channel blocker, then it has to be working in the contraction of the ventricles or the atria to slow the influx of calcium, to slow the rate. Does that make sense? No? Did I lose you?
Yes.
I lost you?
No, makes sense.
Oh, I mean, I want you to tell me if I lost you.
I was
Okay.
just slow to answer your first question.
So it's just, when you look at it, you're like, I have no idea what that picture looks like or what that means. But what I want you to see is that this is why those drugs work, is because we have that influx of sodium. We have that influx of calcium. So if we block them, then it can slow things down. Okay?
So just to clarify.
Yeah.
The difference between whether they're getting the sodium blocker or the calcium blocker is what their actual conduction is doing. Is
Oh, absolutely.
That's decided.
It would
That
be
makes sense.
arrhythmia dependent and patient dependent.
Okay.
Yeah, absolutely.
So it's not just like, oh, you have the hypertension, here's the hydralazine. Like they're looking, those drugs specifically look at the electrical activity.
So when we're talking about antiarrhythmics, yes.
Okay.
Can you guys hear her? Did you hear her? Yes. Okay. Now don't get me wrong. When you first get diagnosed with hypertension, like my husband was diagnosed with hypertension, I don't know, like 3 or 4 years ago. And the doctor just like automatically slapped him with Valsartan.
Yeah. Like they just.
And there's a reason for that though. We have our most commonly prescribed drugs that work for the majority of humans, right? And less contraindicated. The more specialized we get, the more specialized our medications get, right? The more comorbidities, the more contraindications we have, the more specialized we're going to get, okay? So this explains it a little bit more, but just a little more science-y, okay? So this is a muscle fiber. This is what it's showing you. This is a cardiac muscle fiber, okay? And it's telling you that electrical stimulation opens a calcium channel, which is why our calcium channel blockers work by slowing the calcium, right? So we talked a lot about the cell membrane. We talked a lot about how things go in and out of the cell. This is telling you that in a normal cardiac muscle tissue, in a normal cardiac conduction, electrical stimulation opens this channel and calcium comes in. And that is what's necessary for the normal conduction. Okay? And then it says down here that calcium enters the cell and inactivates. So if you've ever seen a person with an MI or talked about an MI, we know that troponins are the labs that we run to see if there's ischemia, damage to the heart muscle. So if there's damage to the heart muscle and there isn't calcium influxing in and there's a lot of damage, your troponin's not inactivated anymore, which means it's floating free in your serum, which is why it's high when they're testing it. Makes sense? You look confused. I want to make sure you're okay.
Never been good at science, so it's never been that gibberish.
Nursing is a science degree, my friends. That was meant to be funny. That was meant to be funny, not picky. And sometimes you don't have to be super sciencey, but when we talk about pharmacology specifically, it really is all about chemicals. It's all about chemical reactions and electricity and how and why it happens in the synapses and blah, blah, blahs, right? It literally all comes down to the anatomy and physiology and the science of the human body. And I'm sorry that you just realized that. My bad. I feel like I just ruined your life. No, you're gonna be fine. You're gonna be fine.
Yeah,
So what part are you lost
I'm gonna be honest, I'm lost from them.
on?
She said I've been lost. So you have to remember, this is literally the first step, right? This is literally the very first, like, okay, this is what it's supposed to be. And then what do we do when things go wrong? So I guess for me to help you, I need to know exactly what isn't clicking.
So I guess I don't know.
Okay, I can do better on that. So when I say calcium or when I say like contraction or relaxation or depolarization,
So like, back in the day when I had to learn the table.
like the periodic table.
Yeah, never remembered that. So it's just like,
The abbreviation of the.
abbreviations are getting me, I can teach myself what.
I don't want you to teach yourself. I'm supposed to be teaching you. The point is for you not to teach yourself. It's for me to give you a leg to stand on so that you can run. She said both my legs are broke.
She's like, I need a crutch. So CA is calcium.
Yeah, I know CA is
Okay.
calcium, but like, doesn't sound goofy, but
No.
NA.
That's
and
sodium.
Yeah, but where do you get NA and sodium?
I don't something you got. It's gave it, you know.
That's-
like
You give that to
potassium.
Jesus and you just know that that's potassium's you just, those are the ones you just have to know.
So, and I understand that that's probably something that's frustrating,
Yeah.
but they are right. Like it is what it is. The periodic table of elements is what it is. So at some point you have to learn what those letters are because they will be for the rest of your career.
Yeah.
At some
It's
point-
never going to say,
Kind of like
Yeah.
the thing.
Yeah.
The potassium.
At some
So
point,
going
the
forward-
Greek or the Latin or whatever.
Time out.
is-
going forward, when I say the abbreviation, I'll say what it is. Okay? That works. Okay, this, I hope you know, is a normal electrical conduction heartbeat. Okay? This first little guy is your P wave. This is where your SA node fires. This is where your atria contract. Okay? Oh, I'm sorry. This is where the atria fill. Because that's the first step. They have to fill, right? The atria has to fill. So your P wave is what starts your whole cardiac cycle. Okay? So your SA node is firing, your atria are filling, and then we have this break. Because what has to happen?
Relaxing.
Relaxation.
So that's
Our
like-
AV node, yes, kicks in and says, hey, my atria is full. My atria needs to relax or contract. So that means my ventricles need to relax and fill. So then when I get to my, can you guys see me? Are you following? My Q down here, my R up here, my S here, my QRS complex is when my ventricle contracts. Okay, so you see atria fills, atria contracts, we pause, the ventricles fill, and the ventricles contract.
Can you do that one more time?
The atria fill, we contract.
The hump is the contract.
The hump is the filling
Okay.
and contracting.
But
So
the hump.
the beginning is fill,
Filling.
the end of the.
It is filling and then,
Gotcha.
right? Okay?
And then the pause is the line, and then the.
Our pause is our AV node, where our ventricles can fill. Our QRS is ventricular. QRS is ventricular. That is your ventricular contraction. So if you think about the picture, our atria are a lot smaller than our ventricles, right? Which is why our P wave is so teeny tiny. And then my big cardiac output is with my ventricle, because that's a big out to the body or out to the lungs. Okay? We need more oomph here. We need more power here. Okay? This little guy is a T wave. We don't worry about him very much unless you're having a STEMI in you. But ventricular repolarization, which means it is gearing up. Like it's repolarizing. So depolarize, I'm just like chilling over here, right? If I'm repolarizing, I'm charging up. Okay, so I'm charging for my next heartbeat. Because that's how smart our bodies are. That's how smart our heart is that it's always looking ahead.
So with a STEMI is the best. Okay.
Miss Simmons.
After the QRS, how it's like,
This guy?
Yeah.
A pause,
yes,
if you will.
that's all that it is.
Yeah.
Okay, I just wanted to make sure.
Because our ventricles have to, so think about this. If we are contracting here in the QRS, and then we're gearing up over here, there has to be a relaxation.
Is that the AV node or no?
No. Because we already went through. We said P or SA, AV, bundle of His, Purkinje, all up in here in our QRS. And then we need to have a pause so that our muscle can then relax.
So it's literally just.
It's literally just a pause. It is a normal pause.
Is that where you, this might be a stupid question. Is that where you would hear like the S3 sound if there's something wrong?
Maybe, yeah.
Okay.
And then the T wave is the actual relaxation of the ventricle, you said, or that's just gearing up to like relax?
It's charging.
Gotcha.
Getting ready to run. We're not going over this yet.
Okay.
I love this. I love that it's here, but we don't need this yet. Okay. This is not why we're here. That comes in 3 months. Okay.
Yeah, you made that. That was great.
That makes me very excited for 3 months from now.
You should record and put that on YouTube for people. Because
It makes so much sense.
listen,
Okay, so remember we talked about Starling's law. They also refer to it as the rubber band principle. And remember we talked about when there's a sense of stretching. I want you to think about your bladder too. Your bladder also goes with Starling's law. Because when you fill something, we have stretch receptors. We talked about receptor sites on Tuesday. We have receptor sites everywhere, but they're all different. There are all kinds of different receptor sites. But when we have muscles that stretch and then need to empty, we have stretch receptors that say, okay, I'm full enough, let's contract. Okay? So that happens in the heart, that happens in the bladder, that happens in the uterus during active labor. Not all the time, only during labor. Okay. So I do want you to become familiar with these terms at the bottom. Afterload, or I'm sorry, preload is I'm pouring a pitcher into a cup. The pitcher, the liquid that's in my pitcher going into my cup is my preload. Okay. So that's my blood in my left atria. My left atria, that's my preload. Okay. And my ventricle. Right? What is the first thing you're supposed to do if your car goes underwater? Before it gets underwater.
open your door, roll your window down. One or the
Roll your window down. Or open the door, right? Why?
Because if it's underwater, the pressure's too high.
The pressure's too high. If you're underwater and you try to open that door, there's too much pressure on the other side. That's your afterward. Okay. So when I have blood filling my left ventricle, which is my preload, and it has to contract with enough force to get through my aorta to the rest of my body, it is fighting against my afterload. The resistance of the water outside of my door. So if my muscle isn't strong enough to overcome my afterload, we have heart failure. You catching that?
So
That makes
preload
sense?
has to be stronger than the after.
The preload is what it is.
So contractibility.
The contractibility has to be strong enough to overcome the resistance on the other side of the door.
Makes total sense. I
Yeah?
like the way they use them.
Yes.
You follow us till the end, till we're done.
I will be with you in the end.
All of them. Just
No, I can't. I don't teach peds or OB
come on. I think you
or
can
mental
do it.
health. Okay, so we did talk a little bit about systolic and diastolic. We talked about systolic being during contraction, diastolic being during relaxation. Okay. We talked about the RAS system, the renin-angiotensin-aldosterone system, okay, which is controlled by the hormones that are regulating the blood volume. So remember, we talked about it, angiotensin causes vasodilation, right? We talked about aldosterone, okay? We talked about renin, which we're going to talk about again today, okay? Because I feel like we didn't cover it well enough. But when you talk about the regulation of blood pressure, that's what the RAS system is for. That's how we acquire homeostasis, which is balance. Okay? We talked about right-sided failure versus left-sided failure, and I feel like you guys had a very good grasp on right versus left and the symptoms that went along with it on Tuesday. Do we need to talk about that again? So was it a waste of time or are you glad?
No, I'm glad they shared.
Good.
I almost feel like that quick run through with these slides was better than what we got.
I told, well,
Yeah.
that was my goal. I wanted it to make more sense.
With just some quick. Yeah. Hopefully, I just did a quick. If you need.
Guys, did I never share my screen? Are you so for real and you never told me? There is 44 people in this and you did not tell me?
To be fair, I was late coming
Oh.
in, and so I was just like, well, maybe there's a reason. I'm not
my-
going to be the one to speak up.
Oh, because she was late.
4 people said, I'm not gonna be the one. Oh, Ethan.
I said your
You gotta
name.
talk out loud, my friend. You gotta talk
I
out
said your name
loud.
about 5 times and you ignored me.
You did not.
I didn't hear anything.
Nobody heard it. Nobody done heard it, not one time.
2 feet.
Mm-mm. Nobody heard it.
Next time, wave your hands in front of the camera.
Well, you know what? My TV back there isn't working. So when I'm teaching and my TV is working, their chats pop up on the screen and I can see all of their faces. I got this little teeny tiny screen down here. You gotta talk to me.
I'll try to pull it up just.
Okay.
Maybe.
I really thought there were technical difficulties or something, and I just wasn't
No,
hip
it was
to the
just
know.
me being stupid.
Could you please let me into the meeting? Yes.
Can you see? Were you at least following with the PowerPoint? Okay, thank you.
Yes, I was.
Okay, thank you so much.
Appreciate that.
Okay. So we did talk about this, but we're going to talk about it a little bit more. Okay, so if I'm going too fast, I need you to tell me to slow down. All right. Okay, so we did not talk about MAP. So you know when you take a blood pressure and there's this little teeny tiny number that's right next to it, and you're like, what does that mean? That doesn't mean anything to me. Okay, that little tiny number is very important. Okay, that is your mean arterial pressure, your MAP. Your MAP must be greater than 65 for your brain and your vital organs to be perfused properly. So when you come up to me at clinical or when you're a new grad or whatever, and you run up to me and you're like, oh my God, my patient is hypotensive. They're, and I'm just making up a number. They're 100/64. My question to you is going to be, what is their MAP? Because I could be 100/64, but if my MAP is greater than 65, that means I'm fine if I'm not symptomatic. I'm fine. My brain and my organs are perfusing just fine.
That means they're getting enough.
That means they are getting enough oxygenation to all of my vital organs and my brain. Okay? So when you get into critical care and you see people on what we call vasopressors or pressors, you will see in the MAR that the goal is to titrate for a MAP greater than 65 so that we can oxygenate our vital organs. Okay? That's all I want this to mean to you right now. I am never going to ask you to compute a MAP because I don't even know how to do that, man, to be honest.
So for those manual girls, we need to use the unvalued.
No, well, first of all, I love a manual.
Okay,
I love a manual all day. I trust my ears more than I trust a machine all day, any day.
but if they're hypotensive,
But if my patient is hypotensive, and especially if I'm titrating pressors,
Yeah.
never in a million years would I be doing that with
Okay.
a manual
That makes
blood
sense.
pressure. Yeah. Okay, so we talked about RAS. Let's see if this is a better diagram. I'm hoping so. So we know that our liver and our kidneys work together when they sense an issue with blood pressure. Okay? And we know we have the juxtaglomerular cells in the kidney that says, hey, I'm not getting enough blood flow, guys. I need more pressure. I'm not getting enough oxygen. Because, by the way, you're going to hear me say this a million times, it all comes back to oxygenation. Why do you think airway is A, B, C? It all comes back to oxygen. So my kidney says, my juxtaglomerular cells say, hey, I'm not getting enough blood. I'm not getting enough oxygen. I need you to raise this blood pressure. So it releases renin. Okay? My renin and the angiotensinogen from my liver form angiotensin 1.
So the renin brings down the blood.
increase.
It just starts.
Okay.
It just starts the cascade. It's a whole process.
So the angio
Tensinogen,
and renin have a baby.
they have a baby.
And then you
There's a mama and a daddy, and they have a baby called angiotensin 1.
Okay.
Yes. I like that image. Okay. So then I drop him off at daycare. And the daycare is the lumps.
Okay, that makes so much
Okay. And daycare, they do a lot of work. and they converted my baby to angiotensin 2.
Now then, are you true?
And now my baby is potty trained. He made it to toddler. Oh, you got, I like that. I like that. Are you following? Is everybody following that? Because I kind of like it. All right. So now angiotensin 2 tells my artery to contract, which causes a higher pressure. Can you guys hear me okay? My screen just like flashed out.
Yeah, you just cut out.
Do you want me to go on my hotspot? Is that the first time?
It's the first time, but you're back now.
Okay, let me know as soon as it happens again and I'll switch over.
All right, thank you.
So the angiotensin 2 tells my arteries to constrict. So this is a garden hose. And my garden hose is this big. But now all of a sudden I made my garden hose this big. So that's going to increase the pressure of the water going through the hose, yes? Which is going to increase my blood pressure, which is going to increase the perfusion to my kidneys. So my juxtaglomerular cells will say, oh, thank you. You did what I asked you to do. Okay. Then we have release of aldosterone. The adrenal gland lives on top of my kidney, right? We talked about that on Tuesday. That's where it lives. And I made a fumble on Tuesday. So I want you to listen to the words that are coming out of my mouth. All right. So we know, if you don't know, we have a drug called spironolactone, which is also called aldactone. That is a diuretic, right? It causes us to pee. Okay. The RAS system, the point of the RAS system is to increase the blood pressure. That's the whole point of it. Because my kidney's not getting perfused. I need to increase my pressure to increase my perfusion, right? The hormone aldosterone causes you to retain water and sodium. What happens when you have too much sodium? The blood pressure goes up. What happens when you have more volume in your body? Your blood pressure goes up. So angiotensin 2 not only causes vasoconstriction of the arteries to increase the pressure in the hose, it also says, hold on to everything so that we can increase the pressure. Does that make sense?
Yeah.
Okay. Okay.
Jessica, could you let me in on my cell phone, please?
Yeah. Do we need a break? Or we go? Are we good? We're good.
Okay.
Good? Okay. Okay, so hypertension, it kills a lot of people. They call it the silent killer because most people don't know they're hypertensive until they just go to the doctor one day and all of a sudden they're hypertensive. And we don't know how long they've been hypertensive. They're like, I've had a headache for 3 months. I wonder why. Right? So, especially with like your young men or when we have a really strong genetic component, like I swear my husband's whole family is hypertensive. So even after losing 100 pounds, he still takes his valsartan. Because, I mean, don't get me wrong, they cut it in half, but he's still taking it. His mom's hypertensive, his grandma, his uncles, like everybody. Okay? So there is a strong genetic component, but there is also a very strong lifestyle and diet component. So it's very much two sides of the coin. Okay? And when you have both working against you, is when it gets even harder, is when we start combining drugs. Okay? Hypertension can absolutely increase your risk for stroke. Do you know what a TIA is? If a neurology person heard you say mini stroke, they would have a stroke. Do we use that terminology with patients? I do sometimes because There's a huge lack of education in this country with our patients. And I'm telling you, I tell you 9 out of 10 times, if you tell someone your loved one had a mini stroke, they're going to be like, oh, okay.
Transient.
Before I don't tell when they call and tell me fucking like your grandma had a mini stroke.
Right?
Like,
Yes. Because if they called you and said, hey, your grandma had a TIA, you're going to be like, what?
Okay, so what is it?
What is a TIA?
A transient.
It is a transient ischemic attack. Okay? Girl, I'm going to fight you. So, I love your eagerness. Okay? So, transient means it comes and goes. Like a wave. Just comes and goes. Which is why it's mini, right? It comes, it goes. It hits you, you have a couple symptoms, and then boom, 20 minutes later, you're fine. You're just fine. You're fine, right? But a stroke is permanent. A stroke, you have to intervene. A thrombectomy, thrombolytics, which is going to dissolve, right? But a TIA or mini stroke you don't have to treat it. It goes away on its own.
So what causes it?
We're not going to get into that right now.
Okay.
We are going to talk about thrombolytics in a little bit. So, but the point is that hypertension increases your risk for all of these things. It increases your risk for retinopathy, disease of the retina, okay? Vision loss because of the high pressure in the eye, okay? Left ventricular hypertrophy, cardio or coronary artery disease, heart failure, renal failure. Remember, it all works with the juxtaglomerular cells. If they say, oh, I don't have enough blood, they also say, whoa, bro, that's too much, and you're going to kill me. Because too much for too long is going to kill it, which is where we get renal failure. I'm guessing we all know what orthostatic hypotension is, yes? Good. I'm not going to talk about it. So remember, we said there's two sides of the coin. We have genetics, we have lifestyle and diet. So number one, you get diagnosed with hypertension. They say, hey, go exercise, cut your carbs and sugar, eat less fat. Okay? When that doesn't work, we need to add drugs. Typically, a diuretic like hydrochlorothiazide, okay, which works mostly on the blood pressure and we don't actually use it for diuresis. We use it pretty much only for blood pressure regulation, or a beta blocker. Okay, because remember, beta blockers only work a little bit on the blood pressure, not a lot, just a little bit. Hydrochlorothiazide. We'll talk about it next week with diuretics, but it is important that we know that the only diuretic we use for hypertension is hydrochlorothiazide. Hydrochlorothiazide. Okay?
So that's all I use for women.
Hydrochlorothiazide is the only diuretic we use for hypertension. Okay? So then when that doesn't work, we go to step 3. And we adjust things. We change the dose, we change the classification of drug, maybe we throw in an ACE inhibitor, or an ARB, or a calcium channel blocker. We need to do something more because everything else has failed. Then stage 4, ain't nothing working. And now your patient's on 3 blood pressure pills, 2-3 times a day, and they need multi-drug combinations to lower their blood pressure. Because at this point, it's not all diet at this point. This is a big old fat mixture of genetics, lifestyle, and diet. Okay?
Jessica, Miss Jessica,
genetics.
I'm sorry. You said that hydrochlorothiazide was the only diuretic that's used for treating hypertension. What about like chlorothiazide and things like that? I know it like.
So I guess I should have said thiazide diuretics, which is a classification of diuretics.
Okay.
I shouldn't have said it that way. So you are correct. So it is, when we learn about diuretics, we know that hydrochlorothiazide is a thiazide diuretic. It's a classification.
Okay.
So that is the classification of drug that they use. Thank you.
Okay.
That was a good point. So when we talk about ACE inhibitors that end in pril, like lisinopril or enalapril or captopril, right? How do they work? What do they do? So, number one, they cause vasodilation, which decreases the resistance in the hose. It causes the straw to go to a garden hose, dilates the vessel, which will automatically lower the blood pressure. Okay? It also decreases aldosterone, which causes sodium and fluid loss. So remember, if we want to increase our blood pressure, we hold on to water. And if we want to lower it, then we want to let go of our sodium and fluid loss. And remember on Tuesday, I told you that a huge risk, adverse effect for ACE inhibitors is hyperkalemia, because it causes potassium retention. Which, by the way, I did not learn that until I was studying for my NCLEX with UWorld. Never learned it in nursing school. I was using UWorld and I answered a question wrong. And in the rationale is where I learned that lisinopril increases your potassium, which is why I always make sure I teach it. So this truly is the most simple way of talking about the mechanism of action of an ACE inhibitor. And what does the ACE inhibitor do to us that causes non-compliance?
It causes a dry cough.
Dry cough.
Dry, relentless cough. We hate it. So, our watch list, we have the persistent dry cough. And people they really describe it as this like relentless, they cannot get it to go away. We have our hyperkalemia due to the potassium retention. And remember it like this. If ACE inhibitors work on aldosterone, and we know that the drug spironolactone, aldactone, is a potassium-sparing diuretic, which also causes increased potassium, then we know if it works on aldosterone, it's going to increase the potassium, right? Make that link in your brain. Because guess what? If your patient's taking both of those drugs, ooh, that's no good, right? Angioedema, biggest, hugest thing that can happen with ACE inhibitors. And it can happen at any moment. I don't care if it's your first time ever taking lisinopril or you've been taking lisinopril for 27 years. It is sudden, it is life-threatening. Okay? Once you have had angioedema with ACEs, you are, I think it's a car. It is now contraindicated for you to ever have an ACE inhibitor again, and you may never actually have an ARB either. Because ARBs can also cause angioedema. And then we have interactions, avoid NSAIDs, and potassium-sparing diuretics.
Jessica, can you let Tiara back in?
Yes, thank you. Woo. ARBs. What happens? What does it do? Our ARBs end in sartan. We have losartan, valsartan, candesartan, which I've never seen in my entire life. But losartan and valsartan are definitely going to be your most common ARBs. So they bind selectively to angiotensin 2. What does angiotensin 2 do in the RAS system? What does it lead to?
It makes like
Constriction.
vasoconstriction and
Causes vasoconstriction and
It
holds
raises your
on
blood
to the
sugar.
fluid and sodium, right? So if it binds to the angiotensin 2, that means it lessens its capability. It says, hey, I'm gonna take all you guys so you can't do what you want to do. I'm gonna take you. I'm gonna bind to you, take you away.
So it doesn't.
So there's less. It leaves less of them.
So it doesn't let it vasoconstrict as much.
So it blocks the effect, not the production of angiotensinogen 2 or angiotensin 2. So it will lessen the vasocontraction and it will lessen the sodium and volume retention. Okay?
Sorry, is this the one that binds the potassium or no? No. that's
No.
not. Okay.
Good question. I'm really glad you asked that because it's not.
Okay.
This is not the drug that binds to potassium. That's digoxin.
It literally just binds to the angio.
Yes. Yes. People like ARBs because there's less of the cough than ACE inhibitors. So the non-compliance is less.
Is there a reason behind the cough or we're not getting that deep? They don't really.
And on the 2 slides ago.
Okay.
Yeah, it talks about, it's like, I think it's bradykinin. It's very sciencey. But yes, there's a reason. So RAS interpreters, renin inhibition. I might need a break. So the whole point of this slide is that it is contraindicated in pregnancy. I need you to know that.
Those aren't.
All RAS drugs, all drugs that work on the renin angiotensin aldosterone system, ACEs, ARBs, and renin inhibitors, which we have not talked about, are contraindicated in pregnancy. I need you to know that. So if I give you a question that says my patient is 27 weeks pregnant and is having gestational hypertension, what drug am I giving her? Am I going to give her lisinopril or valsartan?
No.
Absolute darn tootly not.
Isn't there one that?
Isn't there one we talked
there is
about on
one.
Tuesday that you can give a pregnant person? What is it?
Nifedipine.
Nifedipine, which is a
You
what?
can also.
Hold on, I just want to finish that one point. What is nifedipine? Dipine. It is a calcium channel blocker. By the way, it is the only calcium channel blocker that you can give during pregnancy. Make sure you know that. Say that again.
You can also give labetalol.
You sure can, but that's a beta blocker. And we
was
didn't
on
get
both.
that, my friend.
Oh.
But yes, I need you to know that nifedipine is the only calcium channel blocker that you can receive if pregnant.
So what of when they give birth during
What?
breastfeeding? What of during breastfeeding?
I don't know if
You
it crosses into the breast milk, to be honest
You
with
cannot take it when you're breastfeeding.
Yeah. So just because it's safe during pregnancy doesn't mean it's safe during breastfeeding because it's different. Crossing the placenta and crossing through breast milk are 2 very different things. So something can be safe during pregnancy, but not safe after.
Okay.
So we talked about our 2 different types of calcium channel blockers, right? Our dipines that work on blood pressure, and then my special friends, my diltiazem and my verapamil, that work on the heart rate. And a very, very important food interaction, which Miss Candace loves to drink grapefruit juice. Thank God she doesn't take any calcium channel blockers. That grapefruit juice is a contraindication. Okay? So these dipines work by causing vasodilation. And our special friends work on slowing the rhythm by slowing the conduction. Remember, we talked about the influx of calcium into the cardiac muscle. So if calcium is being blocked, it's going to slow the rate. Okay. It is definitely not common to treat pediatric patients with antihypertensives. It's going to be the very specific reason why they would need antihypertensives, because they're so tiny and wonderful and supposed to be healthy. When they get sick, it's very, very sick. So, but hypertension is often secondary to a primary disease when it comes to peds. Okay. And then pregnancy safety, it is after your labetalol comes in. Safe alternatives would be labetalol. And then during labor, if you're preeclamptic, they will have you on magnesium. Because magnesium calms your smooth muscle and relaxes and vasodilates. Also makes you very tired. So a very important patient education, right? Because we really need to talk about and think about patient education, because what does patient education look like in this country? It sucks. Sucks. So we need to tell our patients that they need to use a barrier contraceptive, because you get pregnant, your baby's gonna have 3 eyeballs. Just kidding. Just kidding. Maybe a lopsided eyeball. I don't know.
So when you say barrier contraceptive, you mean like extra protection?
So a barrier contraceptive would be condoms. I mean, how many and so you have to think there's always a risk to get pregnant, right? So there's a lot of barrier contraceptives, spermicides, condoms, female condoms, diaphragm, which isn't very common nowadays.
Would an IUD?
An IUD would not be a barrier contraceptive. No, because a barrier is a physical barrier, right? Because birth control fails all the time. So, okay. Woo-hoo. Stop it. Okay. Just considerations for older people. You want to start slow and go slow. You don't want to just hit these people with like the max dose, right? We need to think about their liver metabolism, their kidney metabolism, before we just like put a bunch of drugs in them, okay? So older people in a normal part of aging is an altered metabolism and excretion. Metabolism through the liver, excretion through the kidneys, okay? Risk of accumulation and toxicity. There's just too much drug accumulating in their system, okay? They can't release it well. And then, of course, there's always going to be a high fall risk when you drop someone's blood pressure, okay? So you always check a blood pressure, especially if your patient is dizzy. You want your patient to hydrate unless contraindicated, right? If our patient is in heart failure and already retaining fluid and on a fluid restriction, we're not going to tell them to hydrate, right? We need to use our judgment here. Medication alert, you don't want to crush, cut, or chew sustained tablets, right? So enteric coated tablets, right? You don't want, or ones that have like the little pearls inside, right? We don't want to crush those. Does it happen? All the time. Yes, it happens in real life. Is it supposed to happen in the NCLEX world? Absolutely not.
So what are so I know the capsule words you don't crush. What are the other ones?
Enteric coated?
Yeah, what's that?
I don't say easy.
Enteric coated means that it has a very special coat, like a thick coating on the outside of the pill that doesn't allow it to be dissolved in the stomach acid. It means that it will withstand the stomach acid to go into the small intestine, and that is where it will be absorbed. Because if you don't, because if you think the medical terminology for intestine is entero, so it enteric coated, so it gets to the intestine. Okay. Because if you didn't, It would just dissolve in the stomach.
And it would really, if you crush it, it releases that drug very fast. So instead of it being a 12-hour drug, it's like in an hour, they're gonna get all of that drug right now because it's now not coated and your body will absorb it right away. So like enteric coated extended release drugs are made to last longer. So you get a longer period, but if you crush them, it defeats that purpose and they'll get all of that right now. So it could drop their pressure super quick.
They are not the same thing though.
Yeah.
They're not the same thing. Okay, so what are you guys doing? Is a loop diuretic the first drug used in the step care management of hypertension? Absolutely not. What was the first step? Lifestyle and dietary changes. Okay, and then step 2 was thiazide diuretics and beta blockers. Okay. So summary, always check a blood pressure and pulse before you give any antihypertensives. Okay. Change position slowly. We don't want our patient falling on their face because they have orthostatic pressures. Monitor potassium, especially with drugs that affect aldosterone. Okay, in the RAS system, your ACE inhibitors specifically. And ARBs, but not so much. Not so much as the ACEs, okay? Contraindications for pregnancy. And we want to talk to our patients about lifestyle changes. And we talked about on Tuesday, not to stop your drugs abruptly because we can have rebound hypertension. Bree. You see, I remembered your name because she stops her drugs.
By the way, I've actually never gotten any type of hypertension from it, and I've stopped those drugs 5 times.
Well, thank God. How many times are you going to test your luck, girlfriend?
I actually have to get an ablation at this point. They won't give me any more medicine.
Oh. How are we doing? We're going to go to lunch at 11:30. Are we good to go until 11:30? Stop.
Hey there,
we need to-
I have a question. Not
Yeah.
really a question, a statement. I have to leave my house to head to campus a bit early, so would you be able to let me on my phone when it's time?
Yes. Yeah, just let me know.
Awesome, thank you.
Uh-huh.
Jess, can you give me 2 seconds to lay baby down, please, before you start?
Are you going to show me the sweet baby?
She's asleep.
Oh.
Her tongue's sticking out.
Don't lay her down. She might wake up.
She will, but I can't focus.
Just keep her there. She needs you.
You're right, she does, because she's a boob baby.
Right. And she's going to keep you calm.
All right.
See? All right, down. No, if you need to go put her down, put her down.
Thank you.
Okay. So we did talk about heart failure. But let's just talk about it a little bit more. How are we feeling? Are we feeling overwhelmed? Or are we okay? Everything's making sense. She said, I'm done. My brain isn't braining. How are we all feeling? We feeling okay?
Can I ask a quick question?
Half and half.
Yeah. I've been half. Yeah.
So say we have a patient and like, should we tell them like, hey, if you decide down the road, like, you want to get pregnant, come in first so we can adjust.
Absolutely.
meds?
Yes.
I just wanted to make sure about.
Absolutely.
That was great.
Patient education is huge when it comes to drugs that are contraindicated in pregnancy. So family planning is very important and they definitely need to be educated like, hey, if you ever at some point, if you think you're pregnant, you need to call. If like even an inkling, like you take that test and there's that little faint line, you need to call.
You're thinking,
right? If you're thinking about starting a family, we need to get you on something else.
So I have resistive hypertension. Like
Ooh.
my rest. Now, when I say this, I want you to understand I'm fine. My resting blood pressure is like 240 over 160-ish.
That
I'm
makes
on
me very
7.
uncomfortable.
It's okay. I'm on 7 meds. I get monitored. I have a fancy blood pressure cuff. It goes to my cardiologist instantly. Like it's a modem. Like it's very expensive. I just did a clinical trial for renal denervation, so that's going to come into play for commercial
Oh.
insurance. So that's going to be a form of treatment for resistive hypertension. They went in my
So wait,
kidneys and
time out. Wait. I was just gonna ask you. So is the problem within your kidney?
so my kidney function is 100% fine. Occasionally I go into acute kidney injury because I go into hypertension crisis, which I know I feel impending doom. Like it's a different feeling. But I'm on.
That impending doom is real, isn't it, Carissa?
Yep, I go straight to the hospital, and I don't ask questions,
Amen.
but I do, when I started to, me and my husband, we have had so many miscarriages. It's like, it's a sick
Oh,
joke
I'm
right now,
sorry.
but we're fine. We
Yeah.
have we're successful, but before I got pregnant, I had to see a high risk, doctor. All of my meds had to be switched. It took about like 6 months to safely go on meds that
Yeah.
were pregnancy safe. And I was followed from day one from a high risk doctor, cardiologist, and a nephrologist throughout my pregnancy. So it's possible,
You worked
but it
hard for that, baby girl.
really do have to be cautious. Like I would get so sick, I would have to make my meds into a paste and put them in my cheek and literally just
Mhm.
eat them all day, just to make sure my blood pressure didn't go up. I mean, I was in the hospital like 7 or 8 times because my blood pressure was so high. So it's possible, but it's
It's
definitely
so
a lot of
scary.
work.
Yeah.
So impending doom is very, very real. So if anyone tries to doubt a patient, please just listen to them.
Amen.
Absolutely.
Amen, girl. Okay. So, heart failure is the condition where the heart fails to effectively pump blood, resulting in low cardiac output due to the structural or functional irregularities. That can happen on the right side, it can happen on the left side, right? When it happens on the right side, we see right hypertrophy, which is the big muscle, right? And it happens on the left side, we see left-sided ventricular hypertrophy. Okay. When you're talking about structural progression, this means what the actual physical muscle is looking like. Okay. So stage A, there's no changes to the actual muscle. Okay. Things are happening, but the muscle itself has not changed. B, you have a little bit of thickening, but your signs of disease aren't there yet. Your pulmonary congestion, your peripheral edema, your JVD, your crackles in the lungs, they're not there yet, okay? But your heart muscle is starting to show signs of growth, that hypertrophy. C, you have structural disease with prior or current symptoms. So you have hypertrophy and you are now seeing the symptoms of right or left-sided, whichever you have, symptoms. Okay. And then stage D is refractory heart failure requiring specialized interventions. This is someone that has advanced heart failure.
Question.
Yeah.
Is heart failure always progressive?
Is heart failure always progressive? Yes. Can it be slowed? Yes. And that's where our meds come in, compliance, patient education. Okay. Because the more symptoms you have without being compliant, the worse the muscle will become, the more failure you have.
Did you say this already? If you did, sorry. What's ACC?
ACC.
I'm here, ACCKHK. For the
Is
stages.
Oh, AHA is the American Heart Association. ACC is probably some cardiac something.
Oh, so it's like, it's just the.
They're like the organization. Yeah. And they're the ones that came up with the staging. Like they like invented the staging. I have no idea who NYHA is. I would have to look at
It's the New York Health Association.
Sure. Yeah, sure. I love that. They came up with the functional classification. So class 1, there's no physical limitation. You're starting to have, you're starting to have pump failure, but you can climb up the stairs just fine. Okay, you can do all your things. Class 2, there's slight limitation, but you're comfortable at rest. You climb the stairs, you're a little out of breath because you have, your pump's not pumping good, but you sit down and a couple minutes later, you're fine. Okay. Class 3, you have symptoms with less than ordinary activity. So you can't even do like 4 stairs. Okay. And now you may even have a little bit of symptoms with just like going to the bathroom or walking to your car. No, I don't think they go together. They're just different ways of progressing the disease. Because this is all about the muscle and this is about the oxygenation, right? Tissue perfusion, cardiac output. So class 4, you're unable to perform physical activity without discomfort and you have symptoms at rest. Okay. These are your heart failure patients that come in with exacerbation that gained 45 pounds of fluid and they can't breathe and they're on 7 liters of oxygen on a Lasix strip with a Foley, putting out 6 liters in a day. Okay. So when we talk about homeostasis and compensation might as well be the same word. Because our bodies are constantly compensating. We have compensatory mechanisms for everything that happens in the body, which is how we achieve the balance of homeostasis, right? So our RAS system is our compensatory mechanism. When it fails is when we get in trouble. So it can be our compensating mechanisms are there to save us, but sometimes they're not smart enough to know when to stop. And then they make us sicker. Okay. So if we have decreased cardiac output, our juxtaglomerular cells in the kidneys say, hey, I'm not getting enough oxygen. It activates the RAS system. It increases angiotensin and aldosterone, and it increases the pressure. It increases the sodium and water retention and the blood volume, which increases the blood pressure. Okay? Decreased cardiac output also causes baroreceptor stimulation. What is baro? What are those? What does that mean? Baroreceptors are in your arteries. Okay? So if they're stimulated, it causes a sympathetic activation. What happens with the sympathetic nervous system?
It's a fight or flight.
Fight or flight, which causes increased heart rate and increased blood pressure, which causes increased sodium in fluid and blood volume. What don't we need in heart failure? I don't need more sodium and fluid. I don't need more volume because the more volume I have, the harder my heart has to work. Compensatory mechanisms can hurt us when we're critically ill. Okay. So over time, the compensation mechanisms increase the heart's workload, causing muscle stretching and thickening, which is hypertrophy, and worsening heart failure. So the goal is to reduce the workload over increasing the force. So I hate that it gives you the answer. The first goal of treatment for heart failure is to make the heart beat harder and faster. Hex no, it's already working too hard. Why do you think we have hypertrophy? Because it's working too hard. So why would I want it to work harder? No. Okay. So the goal is to decrease the work on the heart by reducing, here's our words again, by reducing preload and afterload. So the preload, I'm reducing the volume. Load, I'm reducing the pressure outside the door, the resistance that I have to fight against, which is going to lessen my cardiac workload. Okay? Rather than just whipping the tired horse, which is obviously your heart. Okay? So, heart failure stage treatment. This is almost a little too much for us right now, too sciencey right now. But they do have a little note here that ACEs, ARBs, and then these are the angiotensin renin inhibitors that we didn't talk about are preferred and evidence-based beta blocker with diuretic agent as needed. So we want to reduce the afterload with ARBs and ACEs. And then if we need to slow the rate and we need to get rid of excess fluid, we can use beta blockers and diuretics. Okay. So we're really just saying that in early stages, you may just be on an ACE or an ARB or both or a combination. In later stages, when you really start accumulating fluid in heart failure, we need to add on that diuretic. Okay. Eventually, you're going to have a combination. So, when we talk about drugs for heart failure, we have our ACE inhibitors and ARBs, which we've talked about, which blocks our angiotensin 2 and works within the vessel itself. Okay. We have our cardiac glycosides, which we talked about, which is our digoxin. Okay. It increases our calcium. And it helps the contractibility. Okay. We have diuretics that increase urine production and then decreases volume, our blood volume. We have beta blockers that block the sympathetic compensation because remember, what does the sympathetic nervous system do? Fight or flight, tachycardia, hypertension. So our beta blocker is going to try to stop that sympathetic response. Okay. And then our vasodilators like nitroglycerin dilate the vessels to reverse the vasoconstriction. Okay. How are you doing back there? You okay? Mm-hmm. Yeah. I feel like I lost you a while ago.
Yeah, you did.
Oh, geez. Well, at least I'm reading the room right.
She was like, yeah, you lost me a long time.
I was like following with the last two pictures.
I think we need a break. We've been going hard for 2 hours. So, well, and I'm recording myself. How about, are we hungry? Let's just go to lunch. Let's come back at 11:45. Regroup, refresh, pee, drink, all the things. And let's come back at 11:45. Okay?
All right.
All right. Oh, Miss Shelley? Yeah, I follow her on Facebook.
Yeah.
Yeah, she has an NCLEX prep.
So my friend put the NIT. But NIT closed down, so she never took her.
ITT?
Yeah, ITT.
Who is it?
This girl named Samara.
Tamara.
She went there, Samara Moore.
I went to ITT Tech.
So
They closed while I was 3 months from graduating. when they
That's
closed.
what they did. You know, fighting they did.
I went to nursing school twice. They never, because you can't transfer nursing credits. You cannot transfer core nursing credits. Because you have to think about it this way. And obviously, I mean, you guys have gone through our Board of Nursing stuff. You know how important the NCLEX pass rate is, right? So why would I in a million years accept you from another school where I don't know what you were taught, who taught you, and then bank on my NCLEX pass rate with my Board of Nursing when I don't know what your school taught you, right? So the only thing they accepted was our fundamentals. So we had to start in the second semester of their freshman year. And I had to redo every single class with a clinical.
She was able to graduate, right here for, but she waited.
There was a silver lining.
She at least waited 4 years before she took her. So she.
And
took
did she
the
pass?
test, And she passed.
Wow. They say if you wait more than 6 months, your chances of passing are much
That's-
significantly less.
That's why she said she took Miss Shelley's class, but I follow Miss Shelley on TikTok and Facebook, and she is, even with the songs that she be teaching.
I like her. Yeah. I like her style.
She's a doctor
What's a
now,
good
I
time to
believe.
wait?
I think she did get her doctorate, or she's almost did.
Miss Simmons, what is a good time to wait to take your NCLEX?
All right. A little
Am I saying any?
announcement. Oh, well, everybody's not. Where is everybody? And I need everybody to come back online. I have an announcement.
Except it's the one. And it's the thing. Term, it might be off.
What did you say? When is a good time?
Medium.
So I graduated on May 3rd. I took my NCLEX on June 5th. I also was 27 and I was about to get married and I hadn't lived at home in 10 years and I had bills to pay and I really needed to get my license so that I could make more money. And I did not want to wait at all. Like I wanted to get it done as fast as possible. So I literally, as soon as I got my number, I basically scheduled my NCLEX as fast as I could. And I actually had to switch days at work. So the only people that knew I was taking my NCLEX was my husband, who was my fiance at the time, and my manager at work, because I had to get permission to switch days at work. Those were the only two people that knew I was taking my NCLEX. Which brings me to another point. Do not go as a group. Do not go with your friends. Do not tell everyone. Hey, nobody need to know. You don't need to go with the pressure of a group of people, because I'm telling you what, when I walked out of there, it shut off at 75 questions. I walked out there, I was so stressed. My husband, who was not my husband at the time, I opened the car door and he looks at me, he's like, how did it go? And I was like, shut up.
Yeah.
Literally the first thing I said to him.
I wasn't even to the elevator and I called my fiance because I was like, I just failed. It shut off at 85. I didn't know anything. He's like, what? Calm down.
No, I got on 200.
And it happens randomly.
I got on 200.
Oh,
Swear to God.
oh
I
my
told
God.
the wrong person.
Amen.
I passed, but still, my mother, she don't got no.
I'm glad you
sense
passed.
Of,
All right, I have an announcement. Is everyone back?
She was with me, so she's here.
Oh, I know she's here.
She was just with me eating, but I'm like, what's she in there?
All right, well, I'll just repeat it. I got in trouble. Not a lot of trouble. It's our first time. So instead of you guys taking math exam 1, you'll take math exam 2. That's it.
Oh, okay.
Because
It's literally all the exams are all the same. It's just with different numbers. So because you already took math exam 1,
They can't take.
they can't take the same test.
that makes sense.
Test integrity.
That makes sense.
It's, I mean, literally they are the exact same tests, just with different numbers. So
today we're taking math exams too.
math exam 2, and every campus already knows. So, and math exam 1 is hidden from you, so you can't even find it if you tried.
So we'll take math exam too.
2.
I mean,
Yeah, she did. She got a 10 out of 10.
Good job.
You sure will, girl. You sure will. I believe it. All right.
I had a
Did
quick
everybody
question
hear
about-
me? Yes, go ahead.
And you probably said something at the beginning of class, and I'm so sorry. So how do we give them our proofs for today? Because they put in that email a bunch of things that they needed from us, which we don't do the module.
Octavia,
Yes,
what
ma'am.
did I done say?
She said she might
About-
have missed it.
I know she did come in late. I know her, so I get to mess with it.
Yeah, she can mess with me all she wants.
We don't have a ticket to test because
We don't have a module.
yeah, we don't have a module. So let me just hold on really quick. Let me make sure that everybody took their math worksheet. Because if they did, then I can just say, everyone took their math worksheet. Everybody is ready to test. So if you didn't take your math worksheet, then I'm mad at you.
Oh, I did that Monday night. No, I worked last night, so that's why I was late to class, because I overslept by 50 minutes.
I have one. I think I only have one person that did not take their math worksheet. I only have one. So are you here? And do you know who you are? Because I'm not going to say your name. I don't see you. Yeah, so I'm sure that person knows who they are. Everyone else has taken their math worksheet. So I will put that in this chat right here. Okay, are we ready? Get back to business. We didn't take math exam 1, so oh, thank you, Shonda. Oh, you're right here. Oh, that's funny. Okay, back to business. All right, we finished this slide, yes? Yes. Okay, so a little bit more on digoxin. I feel like we did spend a lot of time on digoxin, so I feel like we aren't gonna, ow, my knee hurts. But it works on the calcium channels. So remember, calcium channel blockers are going to block the calcium. Digoxin increases intracellular calcium, allowing more calcium to enter during depolarization, which is hold on. Did I get my words mixed up? Now I gotta check. Now I gotta check. Hold on. Because now I think I made a boo-boo. I did. I made a boo-boo. No,
No.
no. So I want you to make a correlation in your brain. Repolarization, relax. Repolarization, relax. I flipped it in my brain. Okay, I need everybody to hear me because I hate making mistakes. I hate going back on the words that I said. It makes me so mad at myself. So I need you to hear me and I need you to understand my words. Repolarization, relax. That means repolarization, that is when they fill. So they have to be relaxed to fill the chambers, right? Repolarization, relax. Got me? So when this says, it literally, the light bulb just went off in my brain when I read this and I was like, I budged up. Depolarization, because digoxin works on the contraction of the ventricle. So it wouldn't make sense if this was relax, right? Because it works on the actual cardiac contraction of the ventricle. Okay? Please forgive me. I hate when I do this.
So depolarization is when
Depolarization is when contraction occurs.
polarization, relaxation.
Yes. Repolarize, relax. Re. Yes. Okay. So now hopefully it makes more sense. So increasing calcium by allowing more calcium to enter during contraction, which causes the increased force of the muscle to contract, right? And it also slows the heart rate and decreases conduction through the AV node. Remember, AV is when we take a break. So digoxin makes our AV break a little longer, little slower.
The harder, slower beat.
So you have harder, and what I want you to think about this too. Harder, but more effective. Because harder doesn't always mean good, right?
We talked about that.
We did talk about that on Tuesday.
Yeah.
The most important part is that it's more effective. So yes, is the contraction more forceful? Yes, but it's more effective. Okay?
Can you let Tiara back in?
Yes.
So when you take Johnson, because the heartbeats are harder, do you feel that?
She said when you take digoxin and the heartbeats are harder, do you feel that? I don't know. I've never taken digoxin.
I guess I'm just curious.
I don't think so. Like if the contractility is harder?
Yeah, like if you're feeling your heart.
I think they probably feel better. Like not as symptomatic.
I don't think it beats like you could feel it beating out of your chest. It just gives it better, more effective.
We would have to ask someone that takes digoxin. Carissa, do you take digoxin?
I do
Have you
not.
ever-
My heart is fine in that aspect.
She said, I take 7 other drugs, but not that one.
I used to work in cardiology.
What about Bree? Oh, Stevie, tell us.
I used to work in cardiology and worked with a heart failure specialist, and they don't describe it as like palpitations. It's just like your heart's working regular. It's not like a palpitation.
Just more normal.
Yeah, it's like they're normal now. It's not like
Nice.
a palpitation kind of feeling.
That's good, because when you have something that makes someone feel abnormal, you want to tell them that. You want to tell them what to expect, like our patient education with adenosine, right? Okay, so anyway, digoxin increases calcium, makes contractions harder and more effective, okay? Slows the heart rate and decreases the conduction, meaning the electricity, through the AV node, which is already where we have our break, right? That's already where our natural delay occurs. So digoxin is going to make that a little longer, okay? And it results in increased cardiac output, renal perfusion. Because when we have an increased pressure and increased cardiac output, you're automatically going to have better perfusion of the tissue. Okay. Does anybody remember the therapeutic window for digoxin?
0.5.
0.5 to 2.
0.5 to do. What is the antidote for digoxin? Digifab, Digibind, and the other one's just longer. Digoxin immune fab or Dig immune fab. Those are the antidotes for digoxin. And what does digoxin bind to? Potassium. So what electrolyte imbalance would cause an increased risk for digoxin toxicity?
Hypokalemia.
What about it? Hypokalemia. Because there's not enough potassium for it to bind to. Okay? So this tells us that we have a narrow safety margin, which means our therapeutic index is very small, 0.5 to 2. Okay? This is saying pharmacokinetics. This is how fast the drug works. So digoxin works pretty fast. It's excreted in the urine. So we need to make sure that the patient's kidney function is normal or can handle digoxin because it's processed through the kidney. So if our patient is in end-stage kidney disease, or even, I don't know, stage 2, stage 3, it all depends on the patient, right? And their creatinine. We don't want to give nephrotoxic drugs, meaning kidney toxic drugs to someone that's in kidney failure. Make sense?
How often do they test the dig level?
So that's a great question. When you first put someone on digoxin, it's probably daily, like if they're in the hospital when they're put on it. Just like Coumadin, like when you first put someone on Coumadin, they're tested often, their INR. And then when they reach therapeutic range for an extended period of time, it could move out to weekly. I'm not sure. Stevie, do you have an answer for that since you worked in a clinic?
I know more about testing for Coumadin than I do about digoxin.
Okay, no, that's okay. It's a good question though. I just don't know the answer. The half-life is 30 to 40 hours. So that means that it's still going to be in your system for 60 to 80 hours. So it could be in your body for what? Over 3 days. Okay. Toxicity. Our number one hallmark sign of digoxin toxicity is the yellow-green halos, or can also be visual disturbances, listed as visual disturbances. They're number one. And then we also have CNS, headache, weakness, drowsiness, upset stomach, anorexia, and then new arrhythmias. We don't want new. We want to get rid of the old ones, not get new ones. Okay, the goal is to never get new ones. So critical safety protocols for digoxin. You want to make sure that you are taking apical pulse every time. This is huge, NCLEX, huge. If you have an apical pulse that is less than 60 beats per minute, you hold that medication. What do we do in real life? Call it up. We call. We don't give it. We call and we say, hello, Mr. Doctor. Would you like me to give your patient their digoxin? They have a rate of 57. And the cardiologist is going to say, yes, hold, no, give. And then guess whose license that falls on? Not yours. It falls on the physician's because you covered your ass. That's called covering your ass. Okay? And then you put in a note. You put in a progress note and you say, 1427, I called Dr. Blah, 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 and I said blah, 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 and doctor said, give medication. Sign. Okay? Electrolyte warning, we just talked about this. Hypokalemia increases the risk of toxicity. Caution with potassium-losing diuretics like furosemide. What type of diuretic is furosemide?
Loop diuretic.
It's a loop diuretic.
Furosemide is a loop diuretic. It works in the loop of Henle. Well, we're going to talk about that next week. The loop of Henle. There are two common loop diuretics, furosemide being the number one most common loop diuretic. What is the second?
Furosemide.
What is the other name for Bumex? Bumetadine, yeah. Furosemide, yes, it's not as common as furosemide and bumetadine. Both are loop diuretics. Furosemide being number one common, Bumex being number two. Now, remember I said NCLEX is testing on generic, so we're going to try to learn our generic names, not our brand names. So it is bumetadine. Okay? Contraindications would be ventricular tachycardia or VFib, which equals dead. Yes. Heart block, sick sinus syndrome. We'll talk about that later. But these are type of arrhythmias. Okay. Acute MI and renal insufficiency because, on the previous page, it is processed through the kidneys. Okay. Make sense? Milrinone. There's only one drug in this class. Phosphodiesterase inhibitors. And the drug is called Milrinone. It is a short-term IV treatment for severe heart failure unresponsive to digoxin, diuretics, and vasodilators. So you done hit that person with everything you could, and they are still very symptomatic. This is when Milrinone comes into play. I think I've only given it once.
You said that it's only one.
There is only one drug in this classification.
Okay.
Yeah, and it's Milrinone.
And this is literally like your last ditch effort. Everything else.
I wouldn't say like last ditch. It's just like it's just like this is the only case we get. You know,
Gotcha.
This is like the only indication. So,
Miss Simmons,
excuse me, it can only be given. Go ahead.
are you able to let Paige in? She got booted.
Yes, thank you.
Thank you.
Thank you for speaking up. It's really hard on me that I can't see the chat on my stupid screen. Okay. So our mechanism of action is that it increases myocardial cell camp, which I don't need you to know that, but it's important. It increases intracellular calcium. So what did digoxin do with calcium? Increasing it. Makes it beat harder and
More efficient.
more effective. In calcium is going to make the cardiac conduction harder, stronger, more efficient. Okay? Which leads to better oxygenation, better perfusion of our vital tissue. Okay? So, stronger contraction, and it also relaxes the smooth muscle and vasodilates. So it works in both ways. Okay. I would say the takeaway from this is that it is only ever given short term. It is only ever given IV. And it is for that patient that is not responsive to other treatments. That is your takeaway. Okay. So monitoring with Milrinone therapy, it's IV use only. We already said that. Excuse me. When you give anything IV, the onset is immediate, right? It's straight into the bloodstream. We don't need to wait for metabolism and whatever, right? So adverse effects, ventricular arrhythmias. This is not an everyday drug, right? This is a very specific situation drug that is harmful. And you have to be very careful and you have to watch your patient carefully because your patient has a very big risk. It says frequent ventricular arrhythmias. Guess what kill you? Ventricular arrhythmias. Atrial arrhythmias don't normally kill you. Now, they can cause you to have a stroke because of the blood pooling in the atria, right? but the arrhythmia itself isn't going to kill you. VTAC, sustained VTAC, ventricular tachycardia, that gonna kill you. Okay? Torsades, sustained, which is just a crazy VTAC, that's gonna kill you. Okay? So, hypotension, chest pain, thrombocytopenia, what is that?
That's
Low platelets.
low platelet.
Burning at the IV injection site. What are we gonna tell our patient? Hey, this might burn. You probably wouldn't want to infuse this into someone's hand. Okay, anybody gotten IV potassium before? Carissa? Bree?
I have.
You
Yes,
guys ever got IV?
it burns. It burns.
It burns
I couldn't
like a
tolerate it,
bee.
so they had to add saline.
Yes, it burns, it burns, it burns. The thing is, with potassium, you can slow the rate. You can help the patient get more, accustomed to it. You can do things to help. This rate is the rate, and you can't. I'm not messing with that rate with ventricular arrhythmias. No, thank you, ma'am. Okay. So, contraindications include severe aortic or pulmonic valvular disease. Where is the aortic and pulmonic valves? So the aortic valve is when the left ventricle pumps and has to go out to the body, goes through the aortic valve into the aorta through the body. Okay. The pulmonic valve is going from the right ventricle into the lungs. So both of them have a large resistance to overcome. So we talked about afterload, right? We talked about afterload within the left, on the left side. The afterload is that pressure against the car door. So that's my pressure on the other side of my aortic valve, right? But it's also because we know that heart failure occurs in the ventricles. We have another ventricle. So if I have right ventricular failure, if my resistance in my pulmonary artery is too high, that's also considered an afterload, because I have to fight against that from my right ventricle to get into my lungs. Make sense? Okay. Key interaction, do not ever precipitates, means that it crystallizes. When you add two IV medications together in the same thing and they are not compatible, what happens is that it literally will crystallize like a rock candy, which is why IV compatibility is so important when you have your patient on multiple IV drugs going through the same line, or you have a triple lumen and you have a patient in the ICU and they're on propofol, fentanyl, Versed, norepinephrine, vaso, neosynephrine, and you got a potassium running, and you have TPN. And now all of a sudden you have an order for cefepime. Oh boy. Oh boy. That's a lot of stuff, and I can't stop the pressors because they're gonna die. I can't stop their sedation because they're intubated and they can't wake up. IV compatibility is extremely important. Okay?
So will it crystallize like inside your body too?
Yes, absolutely.
That will kill you.
Wouldn't be good.
So the answer isn't just to give them extra IV sites, dude.
Well, it depends on the patient.
Yeah.
It depends on the patient.
Yeah.
Could you put in another peripheral IV? Sure.
Yeah.
Is the patient critical in the ICU and you have a triple lumen? You need to figure it out,
Right.
right? I don't care about this drug.
Okay.
I've never seen it a day in my nursing career. It's an antiarrhythmic. It slows the heart rate. You don't want to give it with a rate less than 60. Okay. Oh, this is a good point. It works specifically on the SA node. So if my SA node doesn't work, It's pacemaker dependent. If my SA node doesn't work, it doesn't work for me. Okay? It's interesting. I think this is interesting. I need to make sure. Because I don't like saying things I have to take back. Yes, this is interesting. So most of us have seen commercials for Entresto of sacubitril and valsartan. So it is the most important thing for this. There's a couple very important things. So contraindicated with a history of angioedema with ACE inhibitors or ARBs. Okay, because it has an ARB in it. Valsartan is an ARB, right? Do not use with ACE inhibitors, must have a washout period. What does that mean? It needs time to get out of your system. How long?
3 days.
24 hours. That's a total guess. I have no idea.
To the on based off the app.
48 hours, just shooting from the hip.
Very good guesses. And I had to make sure I was right because it was in my head and I didn't want to say it. 36 hours. Specifically 36 hours. I was saying it up here and I'm like, let me double check. So I would be very surprised if you didn't need to know that. Adverse effects would include hypotension. Obviously, it's an antihypertensive. Hyperkalemia. It's an ARB, but it works similarly to an ACE. I told you ACE inhibitors have a high risk of hyperkalemia, but so do ARBs. ARBs is just a little less. Okay? The cough, even though it's a less common occurrence, the cough still happens with ARBs. Renal impairment. So we need to worry about our renal function, our creatinine, our GFR. Yes.
So what drug classes?
Entresto is a combination drug, and it's for heart failure. So when you have a combination drug, it doesn't have its own classification because it's two drug classes that come together. So you have the sacubitril, which is a natriuretic, I don't like that word, peptide, which we didn't talk about because I didn't need you to know about them. But it works by lowering the blood pressure, lowering the volume, decreasing the workload. And then you add it with the ARB that blocks the angiotensin 2. If we block the angiotensin 2, what are we doing? What does angiotensin do to the body?
It reduces the blood pressure. Retains.
I want to hear what you're saying.
Doesn't it restrict the, it makes the straw from the hose.
It makes the straw go to a hose. So it vasodilates. And also increases the retention of sodium and water.
Wait, you said it dilates but increases sodium and water?
Sorry, I'm sorry.
I swear the picture's like thin in the middle.
Because we're raising the pressure.
Yeah.
Oh, I hate my brain.
No, you're okay.
But listen, but no, we're blocking. We're blocking.
So
We're blocking. We want it to go down.
So we're lowering with this.
So we're
angiotensin.
vasodilating. With vasodilation, you have the pressure going down. So I wasn't wrong. It does dilate.
Right. Well, we were answering
What was normal? Yes. What's normal is that angiotensin 2 causes vasoconstriction.
It makes
But if we're blocking it, then we're causing dilation. Yes. And then if we're also blocking the aldosterone, we're releasing sodium and water, which also causes potassium retention in the renal tubules. Okay? That's why ACEs and ARBs cause potassium retention, because of the sodium potassium. Did I just lose you a little bit? So
That's the last part.
when we talk, and we're gonna do the kidneys next week. But when you think about the kidneys, remember the picture of the tubule that goes like this? Right? You have the glomeruli, and then you have the renal tubule, and you have the loop of Henle,
Yes.
and the furosemide works down here. And over here, you have where sodium balance happens. And then over here, you have potassium balance happening. And then over here, which we're going to talk about 3 months from now, we have bicarb over here. Okay? So there's different parts of the renal tubule that work on excretion and retention of ions. Okay? So if my drug with aldosterone is causing me to retain sodium and fluid, it's only working on that one part of the tubule. So when the fluid gets to the part of potassium, I'm holding on to it. I'm not excreting it, because my drug isn't making me excrete it. It's
Why-
only making me
kinda-
excrete the
How
sodium.
you gave that example? You was talking about how do a drug know where to go? Like if you in pain.
Right, like how does the drug know where it's going? Because it's the receptor sites. Because it knows where to go for the receptors. It says, I see you, you're my receptor, I'm gonna find you.
So basically, I just want to make sure I understand.
Yes.
So when it's telling them to release the sodium, what's happening with the potassium that it decides to put on?
So I want you to remember, what is normal sodium and potassium? Sodium and potassium normally live on a teeter-totter, right? There's a sodium-potassium pump and exchange at every moment of every day, okay? This is regulated by the kidneys that says when the blood is filtered and it gets to this point, I say, ooh, there's too much sodium here. I'm going to let go of some of this. And then the fluid keeps going and it says, I like this amount of potassium. I'm not letting go or holding on. I'm just going to keep it the way it is, right? So it's our body's way of naturally having homeostasis. But when you have something that interferes with that process, it's not necessarily interfering with the sodium potassium pump, because that happens on a cellular level. It's happening with excretion from the kidneys. So it's not taking into account what your potassium is. It's only doing its job of releasing sodium. Does that make sense?
So it's kind of like they're not working together.
They're not working together anymore.
Okay.
The drug is like coming in
kinda like
between
blocking
them.
that out.
But I mean, that sodium potassium, it's still happening on that cellular level.
Right.
But we're not talking about the cellular level. We're talking about filtration.
Okay.
Okay?
Yeah, that makes sense. I got
Okay.
it. Thank you.
You're welcome. This is just across the lifespan. I don't test a lot on this. More for me, it's important for me that you know that when you have people that are older, you know that their excretion is different. You know their metabolism is different, which means that they could have more of the drug in their body that you don't know that they have because you don't know their metabolism and excretion, right? That's what's important for me that you understand. Children, I mean, you have to know that they need decreased doses. It's the teeny, teeny, tiny little body. Everything in peds is weight-based because they're tiny people. Okay? There aren't a ton of studies for pregnancy, but if it was between life and death and the benefit outweighed the risk, they wouldn't say it's a contraindication. They would say, hey, you're going to die without this. Let's try it. Well, sounds scary. It? Okay. We already know we're gonna pulse check. If you didn't know, I hope you know that your patients with heart failure, we need to watch their weight. If you gain how many pounds in 24 hours? 3. If you gain more than 3 pounds in 24, I thought it was 2.
I thought it was 2 too.
I'm pretty sure it's 2.
At our facility, it's 3.
Is it 3? Somebody look it up.
Yeah.
And more than how many pounds in a week? 5. I know that one's 5. Within a day, it's either 2 or 3. I swear it was 2.
I feel like I'm 8 guys.
Did it say 3? I want to teach what ATI and CLEX said. And I don't want to say it wrong.
The American Association of Heart Failure Nurses.
Yes.
2 pounds.
2 pounds in one day is the American Heart Association of Heart Failure. So 2 pounds in 24 hours, 5 pounds in 7 days is when a provider must be notified. Okay. It's important to remember that milrinone you avoid in severe aortic and pulmonic disease. Okay, because the valve can't handle that resistance. And this is a nice little takeaway for you. Look at that. Look how nice that is. You can add to it. But I feel like it's pretty good. And don't worry about this third one because we didn't talk about it. Okay? Please tell me, oh, today's 2 o'clock. Folks, the math test is at 2:30.
Yeah.
The math test is 2:30 to 3. Lecture today ends at 2.
Why would that with 30 minutes right here?
Because the online students have to try.
Yeah, the online students have to drive to campus.
So are we allowed to
You have to wait till 2:30. I already got in trouble.
Following rules.
Don't let me get in trouble again, girl. Okay, antiarrhythmics. We already talked about this. I really feel like I don't need to talk about this again, right? We talked about this. Yes? She said no. Yes, we did.
just did that today?
Yeah. That's what I meant. We did talk about it today. This is good. So, what causes arrhythmias? So, arrhythmias are defined as changes to the automaticity, your heart's automatic electrical conductivity that it automatically does without anybody telling it what to do, or conductivity, which is the electrical activity of the heart cells. So 5 causative factors. Number 1 is always going to be electrolyte disturbance, specifically potassium. Hypo and hyperkalemia will put you at risk for arrhythmias, dysrhythmias, and cardiac arrest. Very important. Both hypo and hyperkalemia. Okay. Number 2, decreased oxygen delivery. Hypoxia changes action potential characteristics. That means that action potential, that's the electricity, that's the repolarization and depolarization, okay, that we talked about. That means there is not enough oxygen getting to the heart in the coronary arteries. Not enough oxygen, okay? Structural damage. Something has happened to the heart muscle. Something hurt the physical structure of the heart, whether it being hypertrophy, some type of failure, enlargement, dilation. Something is wrong with the actual muscle. Acidosis and waste accumulation. We are going to hit acid-base balance hard in complex care, okay? But this is literally, if you think about acids and bases, it's a chemical reaction. We have acid-base balance occurring at every moment in our bodies. Okay. And drugs, of course. There are drugs, especially arrhythmic drugs, cardiac drugs, other drugs that can cause arrhythmias. Okay. Types of disruptions, we can have rate changes, which can be fast, which is tachycardia. There could be different types of tachycardia. And then slow is your bradycardia, which there's different types of bradycardia. Okay. Ectopic, this is PAC is a premature atrial contraction. PVC is a premature ventricular contraction. These two are normally non-symptomatic. You ever feel like when you're just sitting there that you feel like you just feel this like drop in your chest? You ever felt that?
Or that weird, like,
It's just like this weird, to me, it literally feels like something just like dropped in my chest. And it's random, it happens. That is a PVC. It happens to people all the time. The only time PVCs are a problem is when it's called VTAC. Okay. So usually PACs, PVCs are benign and non-symptomatic. Okay. We have atrial flutter, atrial fibrillation, ventricular fibrillation, which is dead. Okay. We'll go over all of these rhythms in complex care and what they look like. But right now, we're going to talk about how to treat them. Okay.
what are
Panic attacks?
yeah, like
Panic attacks is just tachycardia,
just tachycardia.
but it makes you feel like you're dying. It's your heart, it's your head and your sympathetic nervous system reacting to fight or flight. That's causing the tachycardia. And then your brain is taking everything as a threat to the level of like a climax per se. One thing I learned from my therapist when I was having panic attacks is that it's extremely important that you let your panic attack ride. Because no matter what, you will peak. You will peak. Your brain, your body, you can't hold off a panic attack. It will happen. Now, anxiety, yeah, you can back it off a little bit, right? But once it hits that place, once you let it peak, you will come down. The faster you let it peak, the faster you come down. So you shouldn't fight your panic attacks.
So just have a mental break.
Just let it happen. Just let it go. Or also take Lexapro. Or some other thing like it. And then conduction alterations like heart blocks, where we talk about 1st degree, 2nd degree, and 3rd degree heart blocks. Okay.
You know, you were talking about teaching being important, and I was pregnant and they gave me a med and it put me into a panic attack. And they were like, oh yeah, that's a side effect.
What was it?
Oh, I don't even remember. This was 16 years ago. I was just
So
like,
I
well,
did.
that could have been told to me.
Yeah, I went through IVF for my son. And I've never had a thyroid issue, but when you do IVF, even if your thyroid function is normal, they like sometimes if it's like normal low, normal high, whatever, they're like put you on Synthroid. And I am not allowed to take Synthroid because it will cause severe anxiety and panic. And I was like, I'm never taking that again, especially if I don't need it. Like I was normal, like it was just IVF. Anyways, we need to get through this. Okay, so there are 4 classes of antiarrhythmic drugs. We talked about sodium channel blockers. We talked about how we don't use them often. Okay, it's definitely not first line drug. Okay. Class 2 is our beta adrenergic blocker. Blocks beta receptors and depresses phase 4 of the action potential. What was phase 4? Phase 4. Cell returns to resting membrane potential. Rest. We slow down and we rest. Okay? So let's go through this again now that we fixed our depolarization and repolarization terminology. Okay? So Phase 0, the cell reaches stimulation point and a rapid sodium influx. The sodium rushes it. Okay. So with a sodium blocker, it's happening right off rip, right at the beginning of the whole cycle. Okay. Channel 1, the fast sodium channels close. So they take a big influx and then they close down and say, I don't want any more. Don't give me any more. Okay. Phase 2, the membrane is less permeable to potassium, causing calcium to slowly enter. So remember we talked about like a strainer. When something is semi-permeable, only let some things in. Okay? So it says, potassium, I don't like you. You're not coming in here, but I want some calcium. So this is where your calcium channel blockers work. This is where digoxin works. Okay, on the calcium part. And then with repolarization, repolarize, relax, we have rapid repolarization. Calcium influx stops because we know calcium helps contractility. Okay, I don't want more calcium if I'm trying to relax, right? So it has to stop. And then the potassium can leave. Okay, and then phase 4, I get to relax, I get to rest before it all starts again. Okay? So beta blockers are going to be working on my phase 4. Class 3 is potassium channel blockers. This happens on phase 3, which we just talked about. When the calcium stops, the potassium gets to come in. Okay? And then 4 is your calcium channel blockers, which work in phase 1 and 2 because calcium is at the beginning of the cycle. Okay. And I want you to make a connection between more calcium means more contraction. More calcium means works harder, more efficient. Improved contractility. That's the goal, at least. But that's only for drugs that increase the calcium, right? Like digoxin. So the sodium channel blockers, we talked about lidocaine on Tuesday. That was the only one we talked about. And the indication is for life-threatening ventricular arrhythmias, which is why we don't see it often, because it's only when we need to save lives. Okay. For lidocaine, we have a box warning that it could cause a positive ANA test. Anti-nuclear, isn't that like a autoimmune thing, or is it a cancer thing? Yeah, but for what? Look at that. So adverse effects, we can have new arrhythmias. I told you we don't want new ones. Cardiac arrest. Uh-oh. Please no. Yeah. Lupus. So it is for autoimmune. Yeah. So you could test positive for an autoimmune disease when you don't even have one, is what this means. Okay. You want to be very careful. You have contraindications with citrus, milk, some vegetables, and grapefruit. Grapefruit's the big one. Yeah, grapefruit's the big one.
How does it interact with this?
There's some type of enzyme in grapefruit juice that like conflicts with the like chemical buildup of the drug. Yeah, I looked it up once. It's very sciencey and I don't remember, but I remember the gist of it. All right. But the point is that it works for acute ventricular arrhythmias. So ventricular meaning VFib, VTAC, decreases depolarization, so decreases the contraction. When you have VTAC, the rate can be anywhere from 100 to 250, and it's just huge spikes. Okay, non-sustainable, right? And it is IV. The duration is very short, so that means it has a very short half-life. Okay. Class 2 is going to be your beta blockers. It decreases the heart rate, decreases cardiac excitability, which means it's just like chill. Like you're too crazy. You need to calm down. Okay? It's like giving your heart Lexapro. Calm down. Slowing of the conduction through the AV node. Remember the AV is where we automatically have that delay. So we're just making it a little bit longer. Okay? This looks at propranolol. I'm not saying propranolol is not a common, but metoprolol is way more common than propranolol, especially in acute care. The indications would be SVT, VTAC, but specifically I want you to add to this AFib, A-flutter. Yes, 100%. One of the most common indicators for metoprolol is atrial fibrillation. Okay. If you were to tell me I take metoprolol, my very first question to you is, do you have a history of AFib? What's my next question? If you say yes. Are you on an anticoagulant? Yes. Yes. Yes, yes, yes. Okay. So considerations. I need you to make a connection. Anything that causes something to do with my heart, I need to check the rate. I need to check the rate. I need to check the rate. What is my rate? Less than 60. Okay. If my heart rate is less than 60, NCLEX, I'm going to hold it. Real life, I'm going to call. I'm going to hold it, then I'm going to call. And then if he tells me to give it, I'm going to give it. And then I'm going to put in a note to cover my ass. Okay? So, we talked about on Tuesday, it is a contraindication, should be, is, but it still happens sometimes, that metoprolol or beta blocker is given to a person that has a history of asthma and COPD. Why? They have restrictive airway disease. Beta 1, 1 heart, beta 2, 2 lungs. It can affect the lungs, causing bronchoconstriction, causing an exacerbation of asthma and COPD. Do not forget that. It can cause a loss of libido. Ugh, that sucks. I didn't know that till right now. I swear.
So it can cause the bradycardia.
Oh, yes. Oh, yes. It can cause bradycardia because it decreases your rate. Why would I check your rate?
Right. No, but I mean, like, it can cause heart failure and pulmonary edema.
So when we talk about adverse effects, there's effects that are normal or expected, and then there's bad ones like that. Right? So if you take metoprolol and it's causing heart failure, you shouldn't take metoprolol anymore. Okay? So critical cautions, we talked about on Tuesday that it can mask the signs of hypoglycemia. Do not forget that. Okay? Contraindicated in asthma and COPD. It can have interactions with verapamil. You most likely will not see a patient that is prescribed metoprolol and verapamil at the same time. Class 3, which is our potassium channel blockers, this is our amiodarone. So this blocks potassium channels to slow the outward movement of potassium. This is where, when we mess with potassium, hypo, potassium, or kalemia, this is where we can be in big trouble. Okay? Arrhythmias, dysrhythmias, cardiac arrest. This is why potassium is so important. Okay? The indication is for life-threatening ventricular arrhythmias and maintenance of sinus rhythm in AFib. So remember, I told you we can give amiodarone during a patient having pulseless VTAC and we're performing CPR and ACLS. Life-threatening, right? But we can also have amiodarone, BID, PO twice a day, 200 milligrams, right? Because it can maintain sinus rhythm with a patient that has a history of AFib. So it can be used in IV, life-threatening, and then also maintenance of sinus rhythm with a patient in AFib that has AFib.
What's sinus rhythm? Regular.
Normal sinus rhythm is a normal heartbeat. I need you to do me a favor, because I can tell you don't work in healthcare.
I did, but just have they.
I know, and that's great. And I'm going to tell everybody this. What I want you to do, because we don't have time, and I want you to be prepared as possible, is that over the next couple months, you're going to have patients on telly. I want you to start looking at your telly strips. Okay? Because my goal for this is that when you come to me in 2 months, 3 months, that when I talk about rhythms, you're not looking at me like, this is the first time I've ever seen this. Okay? So please, I want you to become familiar. You don't have to be an expert. I don't expect you to. What I do expect is for you to go to clinical, and when they have that telemonitor, you walk up to that telemonitor and you look at it and you say, what is that? What is that? What does that mean? Okay? What does it look like? All right? I want that for everyone. It's not just you. Okay? So, adverse effects. I hope you didn't take that shit.
What?
I didn't mean to, like, I don't know.
No, I didn't take it.
I don't want to pick, I'm not picking.
No.
Okay. Some people are sensitive. I know.
She's a great minute. No, I'm not that sensitive.
Well, I mean, you never know. Okay, anyways. Adverse effects, nausea, vomiting, weakness, dizziness, pro-arrhythmic effects. That means there's a potential for new arrhythmias. Remember, we don't want new ones. Never want new ones. No, thank you. I don't even want the one I have. We're trying to fix it. Amiodarone specific toxicity. You must watch liver function tests. Big one, thyroid dysfunction. It has a link to iodine. Okay? Too much iodine can kill your thyroid. It is actually a treatment for thyroid cancer, is like straight iodine to the throat. Okay? So, big, huge one for amiodarone is thyroid dysfunction. Do not forget that. Pulmonary toxicity. If I remember correctly, on Tuesday we talked about fibrosis. Pretty sure we did.
We did.
Yes, thank you. All right. Lastly, in this classification of drugs, we have our calcium channel blockers. So we talked about blocks the movement of calcium across the cell membrane, which slows the conduction through the AV node. So more calcium means stronger, harder beats. Less calcium means slowing it down. Okay? Most arrhythmias are too damn fast, and we need to slow it down. Okay? So indications would be SVT, which is supraventricular tachycardia. It's very, very fast with a rate between 151 and 200. We have rapid atrial rates. I think we talked about on Tuesday when you have AFib and it's greater than a rate of 100, it's called RVR, which is atrial fibrillation with rapid ventricular response, or SVR, which is less than 60 beats, and it's atrial fibrillation with a slow ventricular response. Okay, so those are abnormal. I mean, yes, AFib is abnormal, right? But when it's too high or when it's too low, then it's more than abnormal. It's very abnormal, right? Angina, which is chest pain, and hypertension. Adverse effects are related to the vasodilation, which include hypotension, of course. When you have a rapid decrease in blood pressure, your brain doesn't get the oxygen it needs and you go whoop to the ground. We call that syncope. Okay, that's when you faint. All right. Edema, heart failure, and AV block, which is an atrioventricular block. Those are your heart blocks that we'll talk about when we talk about rhythms.
Said she needs to log off at 1 to get the babysitter situation and head to Niles.
Okay, that's fine. Just let me know when I need to let you, somebody let me know when I need to let her in. Interactions, avoid combining with beta blockers, or digoxin because it can slow it too much. Okay. What is an expected outcome of vasodilation? Do you know? It's not on there.
An expected outcome of vasodilation.
Expected.
Decreased blood pressure.
Say that again.
Lower BP.
Well, yes, I'm looking for something else that's not on this paper. On this slide. If I have blood rushing to the surface of my skin, what does it look like?
It's flushed.
Flushed. Flushed skin. If I have blood rushing, what is your blood pressure normally like if you're having an MI?
Wait.
Elevated.
Super high. Okay. And what do you think would happen to your head?
Oh,
Severe headache.
Isn't swollen?
Super red.
I'm leading you into thinking about syncope and like blood not getting to your brain. But my
Is it
point,
metastatic hypertension?
no, I'm
Hypotension?
going the opposite way because I made a point of saying that the patient is hypertensive. Okay. An expected outcome of vasodilation, specifically a vasodilator like nitro, is a headache because of the mass dilation everywhere. Put that in your back pocket. You might need it.
I take diltiazem and I can for sure tell you that I do get a headache from it.
Yep. What do you take diltiazem for?
POTS. My heart rate gets too fast when I sit up or stand
God, I
up.
feel like
The
everybody has
highest it's
POTS
been is in the
nowadays.
170s.
Yep.
I've had a lot of tests done, like a tilt table and everything, and it's fun.
Well, POTS
Especially
is
when
hard
they
to
give you the
diagnose.
nitro.
Yeah, POTS is hard to
Yeah.
diagnose. That's why people get so frustrated with it. Okay, so drug therapy across the lifespan. Obviously, children, we talked about weight base. We talk about the dosage being less. Adults, you want to avoid in the first trimester. Most drugs enter breast milk, so you probably don't want to take it if you're breastfeeding. This is a good example of that. Renal and hepatic impairment, which means it affects both the kidneys and the liver. And then frequent checks needed for toxicity and adverse effects. Specifically, when we were talking about amiodarone, we talked about thyroid, we talked about liver, we talked about pulmonary. Okay. And this is a nice little summary. I like that it Successful therapy requires balancing the suppression of the arrhythmia against the risk of creating a new one. Something to live by. So this is all about coronary artery disease and angina, which is chest pain. And I've told you multiple times that the heart is the only muscle with coronary arteries that can okay. Okay. I'm seeing all your messages. Were we able to? Kalia, the answer is no to that question. Okay, Carissa, that's fine if you're still here.
Okay.
Okay, thank you.
What? Oh, you're welcome. Okay, so the myocardium requires a precise balance between oxygen supply and oxygen demand. Anti-anginal therapy is the pharmacologic restoration of this balance. Angina occurs most of the time because of coronary artery narrowing. Most of the time. There is a variable. So atherosclerotic disease is caused by plaque buildup. Plaque is sticky. Okay. This is literally like fatty, plaquey, sticky goo. And what can stick to a plaque? Platelets. What do platelets like to do? They like to aggregate. You're going to hear me say this a lot. Platelets like to aggregate, which is why we have antiplatelet aggregators like aspirin and
I think that.
it is Plavix. I can't say it. I literally clopidogrel. Thank you. Clopidogrel. Okay. So, which is why this happens here, because one platelet sticks and then it says, hey, let's aggregate. And then more platelets come and aggregate. And then it forms a clot. And then the clot gets bigger because there's more aggregation. And then we have a DVT or a PE. Okay. That's how that happens. And then a little chunk breaks off and it goes traveling and it lands in the lungs where we get a PE. It lands in the brain where you have a stroke, or it lands in the coronary arteries where you have a myocardial infarction. That is how that occurs. Okay. So, coronary artery disease is the progressive narrowing of the coronary arteries, which means it reduces the oxygen delivery, right? Atheromas are fatty tumors that are in the endothelial lining. Endothelial, endo meaning within the lining of the artery. So the fatty tumor is within the lining of the artery. Okay. Atherosclerosis means it is the narrowing of vessels.
So the atherosclerosis, the fatty tumor, is that always in a coronary artery disease?
Atheromas can be a fatty tumor anywhere in an artery, in the lining of the artery.
So that would lead.
Coronary artery disease is specifically the narrowing of the coronary arteries. Now, what is it caused by? Is it caused by plaque? Is it caused by a blood clot? Is it caused by atherosclerosis? Right? I don't know. Depends on the patient. The consequence is ischemia, which is when we have decreased oxygenation and harm done to the tissue, and which results in an acute MI, which is a complete occlusion leading to necrosis, death of the cardiac tissue.
Just to clarify.
Yeah.
Aggregate is like another word for clot.
Yes.
Oh.
But I like to correlate aggregation with antiplatelet aggregators. And you're going to hear me refer to that often because I want you to make the connection. Platelets like to come together. It's like a party. And we need to stop them from partying. Maybe. Yes. We're going to talk about that. Not right now. In like 20 minutes. Okay, so we have 3 different types of angina. We have stable angina. Oh, my ears just started ringing. We have stable angina where there's no permanent damage. The pain is effort induced. So I just ran up the stairs. I just had SEX. I just did something. Okay, that is causing
my heart to not receive a lot of oxygen. So I become symptomatic because my body is working hard to get more oxygen. What does my body do when I need more oxygen? My heart rate goes up. I'm tachycardic. Why? Because the demand is high and I need more cardiac output. I need more oxygen. What else happens? My blood pressure goes up because I need the blood to get there faster. So if I have higher pressure, maybe it'll get there faster. What else goes up? My respiratory rate. Why?
Because
I need more oxygen.
faster it'll get.
Okay? The more oxygen I have, the faster my blood can pump, and the more pressure I give it to get there, maybe the faster I get oxygen. Except my coronary arteries are narrowed, and it's really hard to get there. So when I do strenuous activity, it causes me pain. So what do? I sit down. I rest. This is stable angina that is resolved with rest. Okay? You should write that down. It can also be relieved by nitrates. There are a couple different nitrates. Nitroglycerin is our most common. We also have a drug called nitroprusside, which has a very crazy adverse effect. The crazy adverse, I needed a beverage. Yeah, I'm gonna tell you. The weird adverse effect for nitroprusside is that it can cause cyanide toxicity. It's very weird. Because when it breaks down in the body, the byproducts of nitroprusside can cause cyanide toxicity, which is just wild. It's wild to me. Because what else can cause cyanide toxicity other than cyanide? Nitroprusside. You're going to remember that. Maybe. Hope so. Anyways, the key feature to stable angina is that it's predictable. It's effort related. I know if I do strenuous exercise, my chest is going to hurt. I know I need to sit down, maybe take a nitro. Okay? Unstable angina. This is episodes of ischemia. What is ischemia? Lack of oxygen and borderline almost hurting cells. Not really, not necrosis, because that's the death, but ischemia, bad, lack of oxygen, to occur even at rest. So there's a higher risk of an MI, and it is a pre-MI, so pre-infarction signal. Like, hey, you should go to the hospital. Okay? Key feature is that it is unpredictable. It happens at any time. And you need to be seen immediately. You are probably having an impending MI. Okay? Go to the hospital. How often can you give nitro? Every 5 minutes for how many times? 3 times. If you have to take nitro 3 times, you better get your ass to the hospital. Okay? If you have not been diagnosed with stable angina and it is predictable and you know how this is happening for you and you know that, oh, I'm just going to take I'm going to sit down and take a nitro, it'll be fine, I have stable angina, right? This shit happens out of nowhere and you done take 3 nitros and your chest is crushing like there's an elephant sitting on it, you better go to the hospital, okay? 3 is called Prinzmetal angina. This is our special guy, okay? This is caused by a spasm of the artery, okay? It often occurs at rest. This is key. Often at the same time every day. Weird. That is a very key feature. often at the same time every day. It can show EKG changes. So the key feature, it is rest induced, so it happens even at rest. It is predictable, the same time every day. And it's caused by a spasm in the artery. Not the narrowing, a spasm. So you may have buildup, but it is literally like spasming into each other, like a leg spasm, like a tightening, right? Okay. You need to know the difference between these. So therapeutic goal, supply versus demand. When your heart needs more oxygen, we already talked about this. Wait. Oh, this is what we want to do. Okay, so we want to restore oxygen to our coronary arteries, to our heart by, hey, calm down, relax, because you're tachycardic, your heart rate needs to go down. Okay? Decreasing the preload, how do we do that? How do we decrease the volume? Diuretics. Okay. Definitely, well, now that I'm looking at that, volume, yes, with diuresis, because you're literally lowering the volume, right? These drugs, beta blockers, nitrates, calcium channel blockers, they reduce the preload by vasodilation. Okay. So really, there's two ways. Afterload, we can decrease the afterload, the pressure outside the door, with beta blockers, nitrates, and calcium channel blockers, because they vasodilate. And then decrease the muscle contractility. We know that if we reduce calcium, we can reduce the work of the heart. We also know if we reduce the rate with a beta blocker, we can reduce the workload. Make sense? Because if all of these went up, you're looking at more angina, right? So in order to have less angina, we need them to go down. Okay? That makes sense? So we talked about nitrates a little bit. They act directly on the smooth muscle and dilate the arteries, okay? There's a drop in blood pressure. Vasodilation is automatically going to lead in a drop in blood pressure. Does that mean hypotension? No. What if your blood pressure is 200 over 120? It's going to drop, but it's not going to drop to a 60 over 30, right? Decrease venous return, which is your preload. And decrease in arterial resistance, which is your afterload, outside the door. In the car, outside the car. Okay. The result is a reduced left ventricular workload. So the left ventricle is working less hard, which in turn is going to lower the amount of oxygen it needs. The more energy we need, the harder we work, the more oxygen we need. If we force the body to work less, then we automatically need less oxygen, less energy. Okay?
Miss Simmons.
Key agents, yeah.
Are you able to let me in on my phone so that I can head to the school?
Yeah.
Thank you so much.
I hate that you guys have to do this. I feel like it really, like, it doesn't interfere with me. I feel like it interferes for you guys. Key agents would be isosorbide dinitrate, mononitrate, I don't like that word, and nitroglycerin. Nitroglycerin is going to be your most common. Also, Inderal. Inderal is, I'm pretty sure it's this. Inderal is pretty common.
No, Inderal.
That it says Indra.
Oh, IMDR. I'm sorry, IMDR. IMDUR. IMDR. IMDR is common for angina. That makes sense. All right. Anyways,
Yeah, mononitrate.
mononitrate. IMDR, mononitrate. Those are common. So you're gonna see, especially with people that have stable angina, that have episodes of angina often, they can take the isosorbide monotrate daily or PRN. Okay. Not like nitro though. They can't take 3 of them every 5 minutes. So we talked about nitro. We talked about how it treats angina. It can prophylactically treat angina with vasodilation. The onset is very short, 1 to 4 minutes. We can IV, it's 1 to 2 minutes, which I feel like it would be even faster because it's IV. That sounds really dumb. Sublingual is 1 to 3 minutes. This is for acute attacks at home or out in the wilderness. Transdermal is going to be 30 to 60 minutes for a 24-hour duration. This is important. If you've ever worked with nitro paste, nitro patches, they are on for 12 hours, off for 12 hours. Do not ever touch this without gloved hands. You will experience vasodilation and you may faint, specifically with nitro paste. Okay? Tolerance can develop. You need proper storage. The efficacy of the drug will decrease. That means the way that it works, how well it works, will decrease if it is in the sun. Nitro comes in a brown bottle to protect it from the light. Okay? So we talked about adverse effects. Headache. Very common due to vasodilation. Okay? Dizziness. All of those CNS, dizziness, fatigue, weakness, syncope, this all happens from decreased oxygen to the brain. Okay? Reflex tachycardia. This is, it's a compensatory way for your body to be like, hey, we just had massive vasodilation. What's happening? Do we need to work harder? Like, what are we doing? Because nitro doesn't work on the heart. It doesn't work on the rate, the contractility. It only works on vasodilation. So it can cause your heart to be like, whoa, bro, why'd you do that? Maybe we need to work harder because I need more cardiac output. Okay? It's just like epinephrine. If I give you epinephrine, your heart rate's going to skyrocket. Okay? And then we also talked about the flushing, facial or skin flushing. It is contraindicated with severe anemia, head trauma, or cerebral hemorrhage. Because why do we get a headache? There's blood rushing to our brain. If I have a brain hemorrhage and I take nitro that causes the blood to rush to my brain, I am going to bleed out and die.
Viagra.
Okay? Very important contraindication. Do you know what sildenafil is? It's Viagra. Viagra was first introduced as I believe, an antihypertensive because it causes vasodilation. But when they did studies, they said, wow, this causes an erection. How about that? Okay, so you do not want to take Viagra, sildenafil, and nitro at the same time, because then you would have double dose vasodilation and you would not fare very well.
Never knew that the word patient.
Sildenafil?
Yes. He got it but he would not tell me the name. He kept saying they get it from over there.
Get it from over there. It's a parrot. It's over there.
Open the door and
I need it now.
he was like, "It's over there." I'm like, "I don't see it like." So the camera, I was like, you know what? It's because you're young. And he's like, you know, I'm just like, it's Viagra. I said, you could have said that. We've been doing this for 30 minutes.
You said, I don't know that word. My man don't need that. Also, it may decrease the anticoagulation effects of heparin. I know that we are due for a break, and you've been standing. Is it because you want to stay awake?
Yeah, yes.
Poor Candace. Did you work last night? Yeah, I can tell. We only have 40 minutes left, and I really want to get through this. I'm not bothered. I'm checking with you. If you need a brain break, I can give you 5 minutes, not 10. Do you need a brain break? It's okay to say yes. Yes. Okay. 5 minutes. 5 minutes. 126.
Can you let me in
Yes, I can.
on my phone, please?
Good.
Yeah, they don't. Oh, sorry.
I feel like today is going really well.
Mm-hmm. Question.
Yeah.
How long did you with the background past this class? Like,
The first time I went to medical, or the first time I went to nursing school, because were you there for this conversation? I went to nursing school twice, at no fault of my own. My school closed. And I had to redo everything twice. It was not my fault. But the very first time I took pharmacology, I had absolutely no healthcare background. I will never forget the first clinical I ever had, and the first butt that I wiped was a guy with, oh my God, spina bifida. And he had no butt. It was a non-existent butt. It was just a hole. And thank God he was turned away from me.
Because you caused it.
I went to nursing school the first time with no, and then I did start as a tech, like midway probably, but no, I did this class the first time and I passed without a medical background. And this is why I talk about how important it is for the anatomy and physiology aspect, because you truly do have to understand how the body works. And that when you're in nursing school, you really just stay in this like fight or flight. I didn't know I was still on. I didn't know.
Hey, I was listening to you yap.
Wait,
Yeah,
what?
it's quite beneficial to hear you
Oh, I'm
speak about
sorry.
it. No,
I didn't want to disrupt your break. I'm back.
No.
I'm
No,
back.
I was listening.
I'm sorry. I'm glad you said something. So it's really, what was I saying?
The A&P behind it.
Oh, you need to be able to understand why it's going wrong, because drugs happen on a cellular level. And to tell you that new grads understand this concept is a lie. Most new grads, they have struggled to survive getting through nursing school. It is a Hail Mary. They finally made it. And now you're working, and it is going to take experience, years, for you to even understand why it's happening. Now, you can have somebody that all of a sudden they're just like, oh yeah, that makes sense. Yup. And they just know, they just get it. That's not the majority. That is never going to be the majority. So I 100% think that you can pass this class without being a tech.
What time?
Aid, STNA,
Sign in.
You have 2 minutes.
whatever you want to call
The
it.
Spotify, yes, we're signing in.
Who?
Lecture's done at 2.
Hey,
Right,
Jess.
that's what I'm
Yeah.
saying. So we have to
When we're done,
Mhm.
can I have like 5 minutes of your time?
Yeah, I've been seeing your emails, by the way. I mean, they're
Oh,
not
have
really
you?
necessarily to me,
Yeah.
but I've been, yeah,
You've been in the loop, so you
I
saw
am.
that?
I am on the loop.
So
Is that what
there's
you wanted to talk to me about?
that, but there's something about it that I wanted to talk to you about.
Okay.
Away from Terry and all them.
Okay.
Okay. Thanks.
Who? Yeah.
Okay.
Did I?
I don't know. I just saw the.
Oh, here it is. Yeah. Thank you. Yes.
So. If I put my link here, up there, this is
Can I watch it?
Yeah. Make sure she giving it.
I just need a little.
I will do that for you.
He's like, can
And
you be
Miss
my
Simmons?
babysitter for like 5 minutes just to make sure she gets in the house? Okay.
Hold on. What'd you say, Mike?
I was just I was gonna ask. I know you're very busy, but what are the chances that you're gonna do a study guide?
So announcement. We're not allowed to say study guide. I get in trouble for that.
Okay.
Jessica says
Blueprint.
no. Jessica gives key points. Jessica
Okay.
Simmons does not give study guides. Wink, wink. I give key points. Very important, clear wordage.
Okay.
Okay.
Key points
Verbiage
taken.
matters.
Verbiage matters.
Thank you.
And I usually do that by Friday night.
Okay, that's awesome. Thank you.
Now, if my
I don't
mother
know the answer
dies
to this
tomorrow, I don't know if I will get it to you by Friday night.
And that's completely understandable.
Okay.
And my morbid. That is unacceptable. I won't be that morbid today.
So I don't plan on her dying tomorrow. I don't think it's gonna happen.
I said to my son, Mark, lips are really dry. He said, your mom, because he's 16, that's what I said, she's super dry. She's powder on the man. He's like, why are you talking about Mima like that? I said, technically, you talked about Mima like that, not me. So.
All right, ready? Let's go.
1 more minute late.
Let's go. All right, beta blockers. The workload reduces. So beta blockers block beta adrenergic receptors in the heart and the juxtaglomerular apparatus. Where is the juxtaglomerula?
In the kidney.
In the kidney. Okay, so it's working within our beta cells, beta 1, 1 heart, beta 2, 2 lungs, and the kidney. Okay. It decreases the sympathetic nervous system, which is why propranolol specifically is good for anxiety because it reduces the heart rate, it reduces the feeling of panic, and help you achieve calmness. But we're not talking about anxiety, we're talking about arrhythmias. So beta blockers, they will decrease the heart rate. Okay? So decreased heart rate and contractibility equals the reduction of the demand of oxygen. Remember, oxygen is a supply demand. If I demand more, my body will fight like hell, like life and death, to get it. Whether that's tachycardia, hypertension, tachypnea, I'm gonna get it in some way, shape, or form. It may not be good enough, but I'm damn sure gonna try. Okay? So, long-term angina management, it can help protect against after you have an MI because of decreasing the oxygen demand. Metoprolol and propranolol are used to prevent reinfarction, meaning I had an MI, I want to prevent having another one, so reinfarcting, okay, in stable patients 1 to 4 weeks after an MI. So I had one, I'm going to start metoprolol to decrease my chance of having another one in the next month. She asked if people that are on beta blockers on them for the rest of their life. If they're on them for AFib, yes. If they're on them for MI prevention, I don't know. AFib, yes.
That's not necessarily mean that they need less oxygen, it's just slowing the heart.
So remember,
ATP. ATP is made where? In the mitochondria. What do I need for ATP? Oxygen.
Oxygen.
The more energy my cellular, all the way down to one single cell, the more energy my cell demands, the more oxygen I must have. More energy is always going to equal more oxygen. Is always going to increase the demand.
So if the demand's too high, that's what
If the demand is too high, you have hypoxia, you have ischemia, you have necrosis, where the oxygen is not getting there. The demand is there. I need it, but something is blocking it. Something is stopping me from getting it. Okay? Make sense?
Yes.
So indications for, oh, that was you. Indications for metoprolol, we can have stable angina, hypertension, stable symptomatic heart failure because it reduces the preload and afterload. It can reduce the workload of the heart. Prevention of reinfarction, arrhythmias like AFib and A flutter. Adverse effects, dizziness, vertigo, impotence. That sucks. Guess what that causes?
Non-compliance.
Non-compliance. Yes. So impotence means you cannot keep an erection. So men who cannot keep an erection, they don't like that.
Okay.
Sometimes, I would say most of the time, their wives don't like that. So if a man is experiencing that type of adverse effect, they're like, I'm not taking that again. Okay. So patient education, huge. Especially men don't like to talk about not being able to keep an erection, especially with young women. Okay. So patient education, not making your patient feel embarrassed, making it seem like it's okay, we are having this open conversation. I'm not judging you. This is not what this is about. This is about your safety. This is about your life and your patient education, your survival. Okay? If you experience this, I need you to tell us. Because if it doesn't get better, and if you say, F this, I'm not taking it, we need to find another way. Okay? So, decreased exercise tolerance, patient cannot mount. Patient cannot mount a heart rate response to activity. Oh, so I take metoprolol, I'm decreasing my heart rate, and then all of a sudden I go for a run, but the metoprolol is stopping me from an increased heart rate to get increased oxygenation because I need more oxygen when I exercise, right? So I'm not able to meet the oxygen demand because the metoprolol won't let my heart rate be faster. Does that make sense?
So they faster.
You're not going to be intolerant to the activity. So yeah, you could pass it. Yeah. Interactions. We talked about this multiple times. Asthma and COPD. I swear to God, if you get this question wrong, catch me outside. Like I'm gonna be so mad. I'll be so mad. Okay. Hypoglycemia. We talked about this multiple times. Okay. Note down here, doses for angina are generally lower than doses used to treat hypertension. So if you are taking metoprolol for AFib, A-flutter, or hypertension, you're probably going to be like 25 milligrams BID kind of thing. If you're taking it for angina, maybe it's 12 and a half. Maybe it's even smaller. I don't know if I've actually seen metoprolol smaller than 12 and a half. I don't think I ever have. I think 12 and a half might be the smallest amount.
Yeah.
But maybe it's once a day, it's a smaller dose. Okay. Calcium channel blockers. We already talked about how this works. Okay. We talked about, no, that was. We talked about how this works more on blood pressure. These, my special friends, work more on, heart rate and arrhythmias. Okay. Indications would be for chronic angina. See, so we can see that these drugs have multiple indications. They're not just antihypertensives. Yeah, that's the classification, but they have more indications than just blood pressure. Okay. So the calcium channel blockers can be used for chronic angina, transmetal angina. And as adverse effects include vasodilation, which could include dizziness, flushing, lightheadedness. Cardiac output, it can cause bradycardia and can put you into heart block. Bad, 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 bad news bears. Okay, new arrhythmias, bad. New heart blocks, bad. Okay, no grapefruit juice. This is a specialized drug. It's not super common. I do want you to make a special note that it can cause a prolonged QT. So remember we were looking at the heart rate and we looked at the QRS and then we had the next little hump, which was the T. So there's a normal length between that first Q and the T, okay? When you prolong that space, that is called QT prolongation, which can cause syncope, fainting, lightheadedness, fatigue. There's another drug, a very, 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 very common drug that also causes QT prolongation. Ondansetron. What is ondansetron? Zofran. Zofran. Would you want to take ranolazine and Zofran at the same time? No. Ew. No, no, no. No, 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 no. Mm-mm. Nope. And you can't take it with digoxin. This is the same as all the other pediatric people. And this is your little summary.
You said don't take the ranolazine with digoxin?
Correct.
Thank you.
It's an interaction.
Oh, it's right there.
Are going to get through this. On. Okay. Lipid lowering agents, hyperlipidemia, hypercholesteremia. They both mean the same thing. It's high cholesterol, high lipids, high fats. High lipids are a primary contributor to atherosclerotic cardiovascular disease. Atherosclerotic, hardening of the arteries, hardening and narrowing of the cardiovascular arteries by plaque buildup. Okay. This is also, they not only is like diabetes a metabolic syndrome, cholesterol is also a metabolic syndrome. Now, contrary to what our pharmaceutical industry in this country want you to believe, hyperlipidemia is more genetic than anything. You can have the most perfect diet and exercise of your life, and you can drop dead from a heart attack from hypercholesterolemia. You ever heard about the guy who's 45 years old? He runs 10 miles a week. He's the healthiest guy you've ever met, and he just died of a massive heart attack last week. Ever heard something? It happens. It happens all the time. And it's because of the genetics.
Yep.
Okay? They want everybody to be on Lipitor and atorvastatin and all the statins. By the way, lipid-lowering agents are statins. Okay? But a lot of it is genetic, which is unmodifiable.
Question.
Yeah.
So my mammal just told me yesterday, well, she's actually got 2 blood clots, and I actually think she might have a GI bleed. She has to get some scopes done tomorrow, but she told me that they have she was trying to tell me her blood pressure medication, and she said it was a atorvastatin. I was like, well, that's for cholesterol. And she was like, well, they told me it's for my heart too. Do you know why? How it's also for your
So
heart?
you can put someone on atorvastatin for prevention of an MI to try to lower their cholesterol, which is what they tried to do to my mother-in-law, and I told them no. Because
Her
it's,
cholesterol is already low, and her blood pressure is already low.
I don't know. I don't know. I wish
Thank you.
I wish I had that answer.
Thanks.
So for me, it's important for you to know the difference between modifiable and unmodifiable risk factors, right? So sometimes a lot of people think that a disease is unmodifiable. That is not true. The disease is modifiable. Even if you think, well, I mean, there's no cure, like it's not curable, it's still modifiable in some way. You can never change your age. You, contrary to beliefs, cannot change your chromosomes. Okay, now I'm not going to go into that. I am supportive of many, many people. Okay, all humans. But scientifically, we cannot change our chromosomes.
Did you see Ashley's message to let her in and came in?
Okay.
I didn't see.
Oh yeah. No. Okay. And we cannot change our DNA, our genetics. Okay. Technically, everything else can change, including the disease. So don't fall for diabetes being unmodifiable. Cholesterol, unmodifiable. Yeah.
Is it type 1 diabetes?
So that is different. We're talking about, that's an autoimmune disease. So an autoimmune disease would fall into a different category, especially type 1 diabetes, because that's the non-functioning at all. I'm talking about everything else.
Okay.
Good question. I would never put type 1 diabetes on a multiple choice question.
So even if, just real quick, even if they're being modified with medication, it's still modifiable because the medication is controlling it.
It's
essentially.
modifying it.
Okay,
Could,
that's what I
whether
thought.
control is happening or
Well,
not.
right, okay.
Modifying can.
Thank you.
So LDL is the bad guy. That is your bad cholesterol. If it's high, that's going to increase your risk of cardiovascular disease. Your HDL is the good cholesterol that is preventative cholesterol that can help you. So we have multiple different types of lipid lowering agents. Your HMG-CoA. These are your statins. Okay, this is your atorvastatin, simvastatin. Okay, your fibrates and niacin, I don't remember the name. They work on the breakdown and the removal of cholesterol by binding to it. Niacin is also a flushing agent. It is a B vitamin. If you take too much of it, you will turn red and flush and itch. My brother used to take it to pass drug tests. Candace's like, yep. My brother did this when he was like 16. The PCSK9 inhibitors, I don't need you to know the names of these. They increase LDL receptors to try to get rid of it. We are going to talk about these, bile acid sequestriants. We are definitely going to talk about these. And we're not going to talk about that.
So is this on the test about acid ones? Or is it going to be on the next test?
No. This is, everything we're talking about today is testable material. Everything.
So we don't.
Okay? What we're going to look at is bile acid sequestriants and HMG-CoA reductase inhibitors, which is your statins. Okay, those are the two where I care about. So these are your most common lipid-lowering agents. Atorvastatin is Lipitor, lovastatin, rosuvastatin, simvastatin. Your most common statins you're going to see is atorvastatin and simvastatin. I've seen pravastatin like in practice, but simvastatin and atorvastatin are definitely the most common. Okay, Lipitor being number one most common. So it blocks the enzyme in the liver that prevents the making of cholesterol. So your liver metabolizes fats and synthesizes fats, right? And this blocks the making of it, pretty much, okay? It significantly increases the LDL, and it slightly, just a little bit, increases the HDL, which is the good one. It can slow the, oh, here we go. I don't remember who said it to me. It slows atherosclerotic cardiovascular disease progression. It can prevent an MI and stroke and reduces the need for revascularization. Revascularization. That means if I lose blood flow to something and I need to manually go in to remove that something to provide vascularity again, that would be called revascularization. So just remove it. Okay. So this reduces the need for it. So it reduces the need that you may need that. Okay. Oh, this drug specifically, there are other drugs that do this, but this drug specifically, it has something that's called a first pass metabolism, which means it first has to go through the liver to be metabolized to work. So if you have a non-functioning liver, it's a no-go. Okay? And then it's excreted in the urine and feces. So it is strictly contraindicated in pregnancy and lactation. Right here, active liver disease or history of chronic liver impairment because of that first dose phenomenon. It can, or first pass. It cannot be given if your patient has any liver disease, whether it is acute or chronic. Important. Because of the potential risk for hepatotoxicity. Put a star next to this. Rhabdomyolysis. Rhabdomyolysis. Olysis. What does that mean? The destruction of. Myo, muscle. This is the destruction of muscle tissue. When you have the destruction of muscle tissue, it releases a very, let me back up. Protein molecules are very large, okay? Every molecule particle is a different size. Proteins specifically are large molecules, okay? They're not meant to go to a lot of places. They're meant to be used for energy and blah, blah, blah. Our bodies need amino acids, yes? When you have the breakdown and release of proteins, this, because the molecule is so large, cannot be filtered through the glomeruli in the kidney. So the increase in the release of proteins damage the function of the kidneys, which is part of the problem with rhabdomyolysis. It will cause a AKI or cause worsening CKD, chronic kidney disease. Okay. So rhabdomyolysis is the release of protein in the blood. The blood gets filtered through the kidneys, but those molecules are so large that it causes damage within the nephrons of the kidneys. Okay? So, am I going to take this drug if I have any liver or renal dysfunction? Absolutely not. If I say to you, ooh, there is a very common adverse effect with statins, and it is leg pain. It's a huge reason for non-compliance with statins. My mother-in-law, I mean, literally a whole month before I stopped, made her to stop taking it because she doesn't even have high cholesterol. Complained, my legs hurt, my legs hurt, my legs hurt. Okay. There's a difference between muscle soreness and like real significant pain. Okay. This is painful. Rhabdomyolysis is painful. Okay. And you have dark urine. You have damage happening to your kidneys. You pee, that pee is amber. Something's wrong. Okay. So if I have a patient that just started on Lipitor and they call me, my leg is killing me. My legs hurt so bad. It's keeping me up at night. Girl, you better go to the hospital. Okay? Because rhabdo can kill you and can shut down your kidneys. All right? Rhabdomyolysis is also increased risk with erythromycin, cyclosporines, antifungals. These are antibiotics, by the way. And metformin. Add that to your list because we're going to get there in a couple weeks. And I would love for you to remember that metformin has a huge risk for rhabdomyolysis. I am running out of time. I hate that. Okay. And no grapefruit juice. Okay.
They just need to stop making favorite.
Girl, that's what I've been saying. They just need to stop making it. Okay.
She said no.
Important. Bile acid sequestriants. So they bind to the fats and excrete it through the feces. Okay. There's something important I need you to know about this. I don't remember. Oh, there is a difference between water soluble and fat soluble vitamins. Yes?
Yes.
Do we know this? Yes. So if something is binding to the fat in my bowels, what am I not absorbing? Fat soluble vitamins. What are my fat soluble vitamins?
I know this few.
A, D, E, K. Know it and remember it. Fat soluble vitamins. A, D, E, K. A, D, E, K. If you take bile acid sequestriants that bind to the excess fat, you are at risk for malnutrition and vitamin deficiencies of A, D, E, K. Oh, it's right there. Perfect. Another thing I need you to know about this is right here, my pearl, my clinical pearl. Other medications must be taken 1 hour before or 4 to 6 hours after you take a bile acid sequestriant.
Why so long that there?
Possibly how long it's in your system.
No, because it can bind and stop the absorption of the other drugs. So it can decrease absorption of other drugs. So bile acid sequestriant, you either take your drugs an hour before or you take them 4 to 6 hours after. This is for high cholesterol. This whole chapter is about high cholesterol.
Are these types of drugs specific? Like, are these used often?
No.
No.
No, statins are way more common. So we talked about blocks the absorption of fat soluble vitamins. Vitamin K is the antidote to Coumadin, yes? So if we're on Coumadin and all of a sudden we start taking bile acid sequestrients and our vitamin K gets all screwed up, we're going to have an increased risk of bleeding. Okay? Drug interactions, because it delays the absorption of thiazides, so your hydrochlorothiazide, digoxin, warfarin, thyroid hormones, corticosteroids. And also, I'm pretty sure this also includes birth control. I'm pretty sure. So I would want to be told if there was a drug I was taking that was going to decrease the ability of my birth control and get me pregnant. Okay? Better get some barrier contraceptives. I don't care about this one. I also don't care about it. Okay. Rhabdomyolysis is huge. And I wouldn't want to take a statin that causes fibro or rhabdomyolysis with another drug that causes rhabdomyolysis, right? And I need to make sure that my bile acid sequestrients are taken away from other drugs, especially these ones. Oop. No go in pregnancy. Ooh. Eyes. Your patients should be having eye exams annually because statins can increase your risk for cataracts. Weird zebra. You don't see that with many drug adverse effects.
That's for all cholesterol ones. The eye exams.
Statins.
Just that.
Yeah.
Okay.
So close. We're so close yet so far. So when we talk about homeostasis is the balance of everything, hemostasis is the balance of your blood. So there are things that affect your hemostasis, and dysfunction of hemostasis leads to, thrombosis, which is clotting, or bleeding because you can't clot, right? So vascular constriction, platelet plug formation because platelets like to aggregate, coagulation cascade, something's wrong here. You're missing a clotting factor. You're hemophilic. Something's wrong in your clotting cascade, okay? And then blood clot formation. So we have thromboembolic disorders that increase your risk of an emboli. And when we have an emboli, it will cause hypoxia of the tissue, anoxia, which is no oxygen to the tissue, and necrosis, which is then death of the tissue. Okay. Hemorrhage disorders, obviously that's excessive bleeding, and it's due to a failure in the clotting mechanism. There's something wrong in the clotting cascade. Less common than thromboembolic disorders, but equally life-threatening, like hemophilia. Okay. If you can't clot, you're going to bleed out. Could be fast, it could be slow, but there's nothing stopping it. So we have
Jess, can you let Chastity in, please?
Yes. We have
Thank you.
antiplatelets that alter platelet aggregation and the formation of a platelet plug, like aspirin or here we go again, clopidogrel, which is Plavix. We have anticoagulants, which stop the blood from coagulating, a blood clot, okay, like heparin or Coumadin. Then you have thrombolytic agents, which dissolve the clot. Very, very different things. Okay? When you think about a blood clot, I want you to think it's like a bruise. What does a bruise have to do? It has to reabsorb into the body. Okay? When you have a blood clot and they put you on Eliquis, they put you on heparin, they put you on Coumadin, it doesn't take away the blood clot. The blood clot is still there. The blood clot has to absorb back into your body just like a bruise. What it does is that it decreases the aggregation. It decreases the risk of the clot getting bigger and then breaking off and traveling and killing you. And it also prevents new formation of blood clots. Because by the way, once you clot once, you're at a 50% risk higher to have another one. Go ahead.
Is
Lovenox is an anticoagulant. It's called a low molecular weight heparin. The chemistry, it is heparin, but the chemistry is different. And I think it's kidney people, I think, do better with Lovenox because the molecules are different or smaller, I believe. Don't quote me on that one. But Lovenox is a low molecular weight heparin, and it is an anticoagulant. Thrombolytics are, we call them TPA, Alteplase. These are drugs that have a very large amount of contraindications that are very important. That if you have any of those contraindications, you are 100% not a candidate for. Thrombolytics are given for people with a embolic stroke, or in some cases, an MI. Okay. So antiplatelets, preventing the aggregation of them like adhering together. We use them for prevention of strokes, which is a CVA, which is a cerebrovascular accident, or this says acute. And it's an adjunct. So you can use this as prevention, like people take aspirin every day. Or you can use this in adjunct to after you've already had a clot, an MI, or a stroke. And aggregation. Did I just cut out for you guys? My screen just went black.
Now I can.
Okay. Okay, good. Red flag includes bleeding, especially with recent surgery or closed head injury. What are your signs of bleeding? By the way, I think because this is recorded, I think I'm just going to keep going. I mean, obviously at 2:00, you can log off, you can leave. I don't care. You don't have to be here.
That.
I'm going to keep going so that when I post this recording, it's going to have
That's beautiful. Thank you.
in front of me or not. Okay. You're welcome. Okay. So what are our signs of bleeding? In general, signs of bleeding. Bruising. No, it is brain bleeding.
Petechiae.
Petechiae. Do you know what petechiae is?
I'm trying to think of the word.
Does anybody not know what petechiae is? Okay. Have you ever vomited so hard that you had little red dots on your face?
Oh.
That is petechiae. That is little teeny tiny broken blood vessels in your face. It happens when you vomit because of the force. of the blood rushing to your face. It's a good example. Most people have experienced that at least once in their life or seen something like it, right?
I love that you just explained it like that. I've never, oh my gosh, that just made it like so real life to make a connection with it. Thank you.
You're welcome. So easy bruising, petechiae, bleeding gums. So we want to make sure that people use a soft bristle toothbrush, right? GI bleed, black tarry stools.
Like dizziness?
And what if it's an upper GI bleed?
Bright red.
No.
No, coffee ground.
Coffee ground emesis.
Oh.
Coffee ground emesis. Now, if you're throwing up bright red blood, yeah, that's a problem. But I'm talking about the most common signs of bleeding, okay? Is going to be bruising, petechiae, bleeding gums, black tarry stools, coffee ground emesis. I feel like I forgot. It'll come to me. So when we do any type of anticoagulation, platelet, thrombolytics, if your patient's already bleeding or thrombocytopenic, no. We talked about aspirin. We talked about, there it is, clopidogrel, Plavix. Brilinta, this is a very fancy drug that people get after a cardiac catheterization if they have an MI. And I've never seen the Z one. So adverse effects, of course, are going to be GI bleeding, acute aspirin toxicity, big one. What is the antidote to aspirin? Look it up. Acute aspirin toxicity can be characterized with fever, coma, hyperpenia, so like crazy rapid breathing, tinnitus, ringing in the ears.
Is it activated charcoal?
Activated charcoal. Activated charcoal.
It says there's no
Activated charcoal is, it's literally like, so activated charcoal is swallowed. If you can't swallow it, they will put it down you. And it binds to poisons.
Okay. This also lists sodium bicarbonate.
You can use sodium bicarbonate, but in an emergency situation, usually it's activated charcoal. Especially this is especially dangerous in children. Especially. Aspirin toxicity is especially dangerous in children. It's called Reyes syndrome. Reyes. Very, very dangerous for children. Okay. Anticoagulants. This is where we interrupt the clotting cascade. We have a normal clotting cascade, right? We get cut. The vessel says, hey, something's wrong here. The platelets come, they plug. We have clotting factors that go into all of it. We have the inflammatory response, okay? So the anticoagulants, they interrupt the cascade. So some of them interrupt prothrombin and some of them interrupt the fibrinogen. Those are two different clotting factors, okay? So they interfere with the normal cascade of events involved in the clotting progress, specifically blocking the conversion of prothrombin to thrombin, which is the second one. And then fibrinogen to fibrin. There's multiple clotting factors. Okay. So we have two really common ones. We have our heparin, which can be given IV or sub-Q. This is for the treatment of DVT, PE, DIC, which you're going to learn about in OB. This is the
We should have already learned about that.
Did you learn about DIC yet?
Yeah. And I literally, the way that I remember it is, damn, I'm confused because I'm bleeding and clotting. And I was thinking about telling you that earlier.
Yeah,
That's a good
one.
I thought you would like that.
She
I
said,
just thought
damn,
about that
I'm
earlier.
confused because I'm bleeding and clotting.
And that's exactly
That's what happens in DIC.
Yeah, I thought
In
you'd like that.
DIC, I like that. In DIC, what happens is that you are bleeding so profusely that your clotting cascade is happening on hyperdrive, and it literally throws everything, the whole kitchen sink, at the bleeding. But what happens is you use it up so fast. So what happens is your body's trying to clot, and it's doing it, but it's hemorrhaging at the same time. It is most commonly seen after or during labor, which is very scary. Anyways, an anticoagulation during an MI or stroke. Generally safer than warfarin. People like it more because they don't have to go through testing. They don't need to test an INR, blah, blah, blah. If you're on a heparin drip, that's different. We do need to track a PTT and APTT, which is a lab, APTT, okay, with our heparin drip IV. But sub-Q heparin, we're not tracking anything, okay? And the antidote, put a big fat star. I want you to know this forever and ever and ever and ever for the next million years. The antidote to heparin is protamine sulfate. It is not vitamin K. Don't put vitamin K, I'll be mad. Okay? Then we have warfarin. Warfarin is more for maintenance, and it's taken orally. There is a maintenance state of anticoagulation, which is why we need to reach the therapeutic level of an INR between 2 and 3. It is contraindicated in pregnancy, which is why if you have to take an anticoagulant during pregnancy, you are giving yourself Lovenox or heparin injections during pregnancy. Okay? Interaction, it does interact with vitamin K. So when you have a patient taking Coumadin, do you want them to change their diet?
No, they want to stay stable.
No, you want to keep your diet the same. If you eat a salad every day and you start on Coumadin, don't stop eating your salad. Okay? Do what you've always done. Do not drastically change your vitamin K levels. Okay? Don't eat more, don't eat less, just stay the same. Because that's when you get alterations in your INR. Because the antidote is vitamin K. Modern anticoagulants. This is our new stuff. The Bigatron, that's Pradaxa. Rivaroxaban, Xarelto, and Apixaban is Eliquis. So the advantage to these medications is the size and nature of the molecules. These drugs do not greatly affect thrombin, clotting, or the prothrombin in the same way as warfarin. So there's fewer systemic adverse effects, and there's no requirement for regular or periodic blood testing. We used to not have antidotes for these drugs, so they were high risk. If your patient had already had like multiple falls or anything, they ain't getting this because we didn't have an antidote. We do have antidotes now, and I don't remember what they are, to be fair, just being honest. And it's indicated for stroke risk reduction in non-valvular AFib, atrial fibrillation, treatment and prevention of DVT and PE. So, of course, the primary risk is always going to be bleeding. Always, 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 always. So, for heparin, you have what's called heparin-induced thrombocytopenia, shortened as HIT. So, the heparin causes a decrease in platelets. Not just a decrease in the making of them, which is why monitoring for signs of bleeding is so important. Because signs of bleeding are going to make us think you can be thrombocytopenic. Okay? Warfarin has a vast number of drug-to-drug interactions, and people don't like all the lab tests. It's annoying. Contraindications obviously would be an allergy. By the way, if you didn't already know this, an allergy would be a contraindication for every single drug. Oh, yeah. Okay, if you didn't already know that. Recent surgery, obviously. A closed head injury, because anything that goes up here is going to increase pressure in your brain. And increased pressure in your brain eventually is going to cause damage to your brain. Okay? So if you have increased bleeding in your brain because you have a closed head injury and you have no clotting factors, or your clotting cascade is ruined, you're going to bleed out in your brain. Okay? Or any condition compromised by increased bleeding tendencies. So patient education, you want to instruct patients to watch for signs of occult blood loss, black tarry stools, excessive bruising, petechiae, or bleeding gums. Do we allow these patients to use razors?
No.
No. What do you want them to use? An
Electric
electric
razor.
razor. I did not explicitly say that in the last class that I taught. And I thought that this was just common knowledge. It's not. It's really not. And when I saw that they missed the question, I literally was at my desk and I was like, what? What? And then I realized that they had no idea and were never taught it, which just blew my mind. Anyway, thrombolytics, the big guns, the big guys, okay? Alteplase, tenecteplase, which is often called TNK. Retaplase, never seen it in my life. There's also one called TPA, but we use TNK more now. This is the most common, TNK. So it works by dissolving the clot, okay? This is the only drug classification that can dissolve a clot, okay? So the dissolution of formed thrombi during an acute MI, PE, or most commonly in ischemic stroke. How many types of stroke are there? 2. 3 if you want to count a TIA, but it's not real, right? So what's my 2 types of stroke? Ischemic, which is a blood clot, embolic, really, and hemorrhagic. If my patient has come in with stroke-like symptoms, am I going to give them TNK? What is the first thing I'm going to do?
Imaging our approach.
Do by doing? What kind of imaging? No, that takes too long. CT. Head CT within the first 20 minutes of them hitting that door. Time is of the essence. Okay? So, these drugs cause systemic clot breakdown, which means it doesn't just happen in your brain where the stroke is, and it doesn't just happen in the heart where MI occurred. It happens every single place in your entire body. Okay? They do not distinguish between a pathological clot in a coronary artery and a protective clot at a recent surgical site. So, adverse effects include severe bleeding because it literally stops you from clotting blood, cardiac arrhythmias, and hypotension. Contraindications include any condition worsened by clot dissolution. I'm going to give you a list because it doesn't list them all there. Hold on. Contraindications to thrombolytics include anyone under the age of 18. Any recent surgery within the last 3 months. A recent stroke in the last 3 months. Spinal surgery. Specifically, they mentioned spinal surgery.
Is that the last 3 months too?
I actually think it's a longer duration because spinal surgery is so, if you lose any blood flow to the spine, you're in big, big trouble. And this even says CVA within the last 2 months, but a recent CVA, okay? Any type of aneurysm, because if your aneurysm bursts in your brain, first of all, you're already at a really high risk of dying. If you get this drug, there's no way you're surviving. Okay? Trauma. Any trauma. Car accident. You fell off your bike. You hit your head. Any head injury. Any open injury whatsoever. And remember, I told you time is of the essence. Time is very important. So when someone has a stroke, we have a terminology called, when was the last known well? Okay. EMS providers, ER people are going to be more, they know what this means. I'm going to explain what this means. If I saw Meemaw at 10 a.m., I left Meemaw's house, she was normal. I went to go to McDonald's and I came back 20 minutes later and Meemaw was no longer normal and she had a facial droop and she couldn't talk to me and make a sentence and she can't lift her right arm. I know that when the provider looks at me and says, when was her last known well time? 10 a.m. That was the last time anyone saw her normal. Because this drug can only be given within 4 hours of the last known well. Now, I will put an asterisk next to that because I believe the company says 6 hours, but every facility does it differently because they want to make sure that this patient is not anywhere close outside of that window. So they use 4 hours as a buffer. Some will even use 3 hours from the last known well, from the last time that person was seen normal. So if I talked to Meemaw on Saturday and everything was fine, and then on Monday I went to go see her and I found her down in the bathroom on the side of the toilet and she's been there for 2 days and she can't talk, she can't raise an arm, she's got a facial droop, she's stroked out. She is no longer a candidate for TPA, TNK. She is outside the window. All right, I am going to, well, there's three slides left. And then I'm going to stop the recording. We're going to take the math test, and then I'm going to start recording again. And you don't have to stay. I will give you the thing, okay? So the other side of the coin is bleeding disorders. This includes hemophilia, which is genetic. Factor 8 and 9 are very common. These are your clotting factors, right? So if you have a deficiency in factor 8, it causes vulnerability to excessive bleeding. Liver disease, because of a failure to produce clotting factors and proteins due to hepatic dysfunction. Bone marrow disorders, because that's where platelets are formed and made. The treatment is you need to replace the specific missing factor. So if it's factor 8, if you replace factor 9, it doesn't do anything. Okay? Examples include anti-hemophilic agent, factor 9 complex. You don't need to know the names of those. It's the point. This is the point. Okay? If you don't give the right treatment, it doesn't work. Okay? Hemostatics, halting the flow. So we have two different types of hemostatic agents. We have systemic, which means it is the whole body, okay? Topical is going to be a localized one single place. So systemic is causes excessive clotting, and it could cause clotting within the kidney. But if you're hemorrhaging, a blood clot is better than dead. Okay? This topical agents, this is used mostly in the OR or in active war zones. Okay? It was actually made for active war zones. And we have something called gel foam. We also have thrombin. And this is an actual physical thing that you can put in a wound or anything, and it will cause the bleeding to stop. Okay. It's used on surface injuries where small vessel damage prevents normal clotting, applied as sponges or sprays. You could see or guess how life-saving this would be in an active war zone to stop someone from hemorrhaging and dying. Okay. No, that's not. And I mean, this is really, I feel like this is common sense, right? So heparin and warfarin in children, we should probably monitor really closely. Yeah? Okay? Please don't make yourself bleed. Please prevent injuries. Pregnancy, warfarin is contraindicated. No. Okay? Heparin or low molecular weight heparin is preferred. And then older adults, liver and kidney dysfunction, start low and go slow. And then you want to watch how with the other drugs that they could be taking that would be contrary. Well, at least I would have one more. Okay, let me pause. Okay, let's. Finish this last one. Ow. Okay. Last chapter quickly. So this is where we're talking about anemia. And the goal of therapy is to restore. I'm gonna try to make this a little smaller so you can fit it all. Okay. So restoring the body's capacity to transport oxygen through the correction of supply deficiencies like iron or B12, or the stimulation of marrow production, which is erythropoietin. By the way, erythropoietin is made by the kidneys. Okay. So the engine, erythropoiesis, and the feedback loop. So this is the negative feedback loop for blood cell production. Okay. So we have the kidneys sense that we need more oxygen because it's getting low arterial oxygen. So the kidneys release erythropoietin. The erythropoietin goes to the bone marrow, which we call myeloid tissue. And this stimulates the production of red blood cells. Okay. This increases red blood cell production, which then in turn increases oxygen carrying capacity, which then oxygenates the tissues. The life cycle of one red blood cell is 120 days. So the essentials for healthy red blood cells is you have to have iron, which is critical for hemoglobin ring formation. Iron and hemoglobin bind together. Vitamin B12 and folic acid, they both form the supporting structure that the cell needs to survive for that 120 days. And then we have amino acids and carbohydrates that complete the cell membrane and the basic structure of the red blood cell. So classifying anemias. Iron deficiency anemia is a negative iron balance. This can happen from menstruation, pregnancy, any bleeding
and rapid growth, especially in children. Then we have megaloblastic anemia, which is a structural deficit. We said on the previous slide that we need folic acid and B12 to make the structure of the red blood cell. So if you don't have those, then the structure is weak. So this leads to, or this can be caused by malabsorption, celiac disease, someone that's strict vegetarian that has a B12 deficiency, and then alcoholism causes a folate deficiency. The third one, we have hemolytic / genetic. This is where there's something wrong with the way that it's being made. So we have sickle cell disease, which is like a crescent shape sized red blood cell. Thalassemia, and we'll talk about that too. And then abnormal hemoglobin S. So erythropoiesis stimulating agents, we have drugs that can stimulate the erythropoiesis. So these act like natural glycoprotein erythropoietin to stimulate the red blood cell production. So it's basically like a synthetic erythropoietin. So this drug is called Epoetin alpha. The brand name is Epogen. There are other drugs, but Epoetin alpha and Epogen are the most common. So the indications would be for anemia, of course, or chronic renal failure, chemotherapy-induced anemia, and then the reduction of transfusion to reduce the need of transfusions in surgery. It is effective dependent on the amount of iron and marrow components, because in order for erythropoietin to be successful, you have to be able to have all of the things you need to make a healthy red blood cell. So box warnings and contraindications. There is a warning of increased death, myocardial infarction, stroke, venous thromboembolism, and tumor progression. And this is because, like, if you have a massive production of red blood cells, you can see increased clotting, increased growth. So you absolutely want to be monitoring the hemoglobin. You want to make sure the hemoglobin goes greater than 11, the goal is greater than 11. A uncontrolled hypertension is contraindicated for this drug. So you want to make sure that this patient's blood pressure is under control, whether that be naturally or with medication. Adverse effects that are common include headache, fatigue, seizure, nausea, vomiting, and diarrhea. For iron deficiency anemia, we need to give iron, literally. So the action to elevate serum iron concentration for conversion. Oral, we can take ferrous sulfate. Parenteral, which parenteral meaning outside of the GI system. Iron dextran or iron sucrose. And then adverse effects for oral iron would be GI upset, anorexia, constipation. If you've never seen an iron pill, they're black, and there is a huge risk, or well, huge adverse effect that it'll turn your poop black. So educating the patient about dark, almost black or black stools is very important. Parenteral. So again, parenteral means anything outside of the GI tract. So sub-Q, intramuscular, IV, okay? Anaphylaxis, phlebitis, which is inflammation of the vein, tissue staining. These are all risks for parenteral iron. And in order to not have tissue staining, we use the Z-track method. Please look that up and see what that is, okay? I don't know if I have a picture of this. Optimizing iron absorption, we need vitamin C to absorb iron effectively. So things that will cause absorption to be blocked would be eggs, milk, calcium, coffee, tea, and antacids. Things that help absorb would be vitamin C. So this is important to know. And you want to wait 2 hours after you eat or drink any of these before you take iron. Very important right here. If the patient, especially children, are drinking liquid iron, they must drink it through a straw because it will stain their teeth. Okay. Iron toxicity and management. An iron overdose results in CNS toxicity, which can progress to a coma and death. The antidote is deferoxamine, which is Desferal. This is for acute iron intoxication. It can be administered IM, sub-Q, or IV. And it binds to the free and bound iron, and it is excreted in the urine. So contraindications include hemochromatosis, which is, too much iron. So if you already have too much iron, why would you take more? Hemolytic anemia, because iron is recycled, it's not lost. So when you have hemolysis, it's the destruction of the red blood cell. So that just means that when the blood cell gets destructed, that iron is recycled and reused. So just because the red blood cell is destroyed doesn't mean the iron is destroyed. So you don't want to give more iron because then you can lead to toxicity. And then if you have peptic ulcers or colitis, oral iron can really, really bother those conditions. Megablastic agents. This is your folic acid or vitamin B deficiency. Folic acid is essential for DNA production. It's extremely important during pregnancy. A rescue drug for chemotoxicity. Sorry, my brain just stopped for a second. Folic acid and vitamin B12 are both essential for how the red blood cell is actually made and the structure of it. So vitamin B12 is essential for red blood cell health and myelin sheath maintenance. Misdiagnosis happens. Folic acid can correct the blood count in a B12 deficiency, but it cannot prevent the neurological damage. So you need to treat the correct reason for the anemia. So for sickle cell and genetic anemias, this is a really good picture of a sickled cell. By the way, sickle cell is extremely painful for patients because these sickled red blood cells get stuck in the very small capillaries and can cause a lot of pain for these patients. So please don't be a jerk and make sure that you are treating your patients with sickle cell anemia that have a lot of pain. You are treating their pain appropriately, okay? Hydroxyurea. Ooh, hold on. Okay. So, hydroxyurea increases the production of fetal hemoglobin in the bone marrow, diluting the abnormal hemoglobin. This can cause bone marrow suppression, so they have to be watched very, very closely. Okay. Considerations, this is a huge one. The liquid iron stains the teeth and it has to be drank through a straw. It's very important patient education. Iron is a leading cause of poisoning, especially in children. So they need to be seen as soon as possible. And these things, because they're bought over the counter, can be bought over the counter, need to be kept away from children. We need to make sure that our pregnant patients are getting in their iron and folate. And folic acid is super important for preconception too, because that neural tube defect happens very, very early in pregnancy. And then in older adults, there's decreased GI absorption, and iron can cause constipation. We all know, at least you should know, that our bowels slow down as we age, and we don't want to increase the risk of constipation. So for the nursing process for assessment, we want to make sure we're looking at the CBC, hematocrit, iron saturation, reticulocyte count. We want to monitor the blood pressure closely. And then the CNS, we want to assess the patient's affect, which is a fancy word for mood, the patient's mood, orientation, and reflexes, specifically with the B12 deficiency. And then parenteral iron, we want to use the Z-track method to avoid staining and irritation. Please make sure you look this up. Oral iron administered between meals for max absorption or with a small amount of food. Avoid eggs, milk, coffee. And then monitor the hemoglobin. You want to hold the ESA if the hemoglobin is greater than 11. So sites of action for the erythropoietin, which is the ESA, by the way. The epoetin or erythropoietin stimulates the red blood cell it's the red blood cell production, okay? You need iron and vitamin B12 folate to have strong red blood cells, okay? And then for fetal hemoglobin production, you need hydroxyurea. The red blood cell lifespan is 120 days, and it needs that B12 and folate to be able to live for that 120 days. So the takeaway is that we need the correct diagnosis. The therapy has to match why it's happening. So iron for iron deficiency, folate for folate deficiency, B12 for B12 deficiency. Safety first, you want to make sure you're reading that black box warnings, and iron toxicity, you want to monitor the hemoglobin and the blood pressure. And then holistic care includes addressing nutrition, managing side effects like constipation, and adjust for lifespan considerations. Successful therapy restores the oxygen carrying capacity while protecting the patient from toxicity. And that is the last chapter. So for this one, I just really want you to focus on patient education and this correct diagnosis. The therapy must match the defect, your safety considerations, and your dietary considerations. Okay? And that's it. So I'm going to get this posted as soon as possible. All right? Bye, guys. Good job on your math test.